So thank you everyone for joining us for the 46th Indian Cooperative Oncology Network Conference. With that, it gives me great pleasure to introduce our program director, Dr. Hemant Malhotra, who is the Director of Oncology Services at Sri Ram Cancer and Super Speciality Center. He's also the professor and head of Department of Medical Oncology at Mahatma Gandhi Medical College and Hospital, Jaipur. Over to you, sir.
Thank you very much, Kashish. So my most hearty welcome to all of you to this 46th virtual ICON conference. And I'm very happy to tell you that this is the third ICON which we are organizing at Jaipur with the help of friends and colleagues. So very, very hearty welcome to all of you. On behalf of my personal side and on behalf of my organizing secretary, Dr. Lalit Mohan Sharma, and the senior management and the faculty of the Mahatma Gandhi Medical College Hospital, we welcome you to this Indian Cooperative Oncology Network biannual conference. And we have a very rich scientific program for you. We were actually very keen to welcome you in person to Jaipur, and that would have given us a lot of pleasure. And we were, absolutely geared up to provide some lifelong good memories for you. But unfortunately, this third wave of the pandemic and the Omicron, that kind of put us off. Now, in hindsight, we do wonder at times whether we did the right thing or not, whether we should have gone ahead with the physical conference. But anyway, welcome to this virtual conference. And I hope over these next 3 days, today, tomorrow, and day after, you will enjoy listening to the scientific deliberations. The scientific program has been planned in minute details to update you on the current happenings in the field of oncology, medical, radiation, as well as surgery. Some very nice competitions are there for our younger colleagues to participate in with some very handsome prizes. So there is something for everybody in this ICON conference. And I once again welcome all of you, and I really hope and wish and pray that you have a good time listening to all the experts, and there is a significant knowledge gain for all of you. So with these introductory words, I'd like to hand over proceedings to the organizing secretary of this 46th conference and my very good friend and colleague at the Mahatma Gandhi Medical College, Dr. Lalit Mohan Sharma. Over to you, Lalit, for the further conduct of the proceedings. Thank you very much.
Thank you so much for the kind introduction and setting the stage for the academics. And first of all, I'm thankful to the ICON committee, Professor Purvish Parikh sir, who has given us an opportunity to conduct the meeting at Jaipur. And as mentioned that we were very keen to have physical meeting, but soon we will have another meeting whenever time permits. So without wasting much time, I request the team to start the academics. Over to you, Kashish, please.
Thank you so much, sir. We'll move on to our first session. This is on head and neck cancer. And it gives me great pleasure to introduce our chairpersons, Dr. A. Ranade, who's a director and medical oncologist at Avinash Cancer Clinic, Pune. And our second chairperson, Dr. Sachin Jain, who's a medical and hemato-oncologist and also an associate professor at IMS and also at Ayush Hemato-Onco Clinic at Udaipur. So I now hand over the mic to our chairpersons. Unfortunately, Dr. Suresh Singh, sir, could not join us. So over to you, sir.
Hello, can you hear me?
Yes, sir. Yes, sir.
Yeah. Good evening, everyone. At the outset, let me thank Dr. Malhotra and Dr. Lalit for giving us this opportunity. And I definitely agree with the sentiment that we should have been there physically at Jaipur. But still, the show must go on and we'll begin. This is the first session and one of the most important aspects of head and neck cancer. And as we all know, in our country, we have so many patients who suffer from head and neck cancers, almost to the tune of around 28 to 30% of males and 25+% of females. So let's, without talking much about the other things, let's get going. let's start with the first lecture.
Thank you so much, sir. Now I invite our first speaker, Dr. Nandini Menon, who is the assistant professor and a medical oncologist at TMC Mumbai. Over to you, ma'am.
Thank you. Can I share my screen?
Yes, ma'am. Please go ahead.
Am I audible?
Yes, ma'am, you're audible, ma'am. And your slides are also visible.
Yeah, thank you so much. So at the outset, I would like to thank Dr. Hemant Malhotra, sir, and Dr. Lalit Sharma, sir, for the opportunity, and the ICON team as well. Today, the topic given to me is on the role of axitinib and Pik3ca kinase pathway in recurrent and or metastatic head and neck squamous cell carcinoma. So this is a not commonly discussed topic, but today's discussion will be on the role of axitinib as well as how the Pik3ca pathway plays a role in metastatic or recurrent head and neck squamous cell carcinomas and how it could be targeted. So the first part I will discuss about the Pik3 kinase pathway and the genomic landscapes and the possible targets. And the second half I will be discussing on axitinib and its role in the recurrent or metastatic squamous cell carcinoma setting. So this is a genomic landscape of head and neck squamous carcinoma, and we know that it is dominated by multiple mutations, especially since it's a tobacco-associated disease. And a lot of mutations are in non-targetable genes, which are tumor suppressor genes, such as the TP53, the Notch, the KMT2D. A lot of times we note that nearly half of the times that there are gene mutations in the mitogenic signaling pathway, that is the Pik3ca mTOR pathway, the PTEN, the RAS, AKT, and other genes in this pathway. And Pik3ca, that is one of the common genes, that is the third most frequently mutated gene. And it has hotspot mutations which are seen in head and neck cancers at particular points. And these are seen in the helical and the kinase domains. So there are basically four broad pathways or biological processes which drive metastatic or recurrent or even de novo squamous cell carcinoma of the head and neck. One is mutations in the mitogenic signaling pathways, that is the Pik3ca mTOR pathway or the RAS pathways, where they influence the downstream signaling and cell transcription proliferation. Then there are pathways which interfere, mutations which interfere with cell differentiation, like the Notch pathways. Then dysfunction in cell cycle, that is the cyclin-dependent kinase P16, especially in HPV mutated cancers. And genomic instability, which is caused by the loss of TP53 and other DNA damage repair genes. So this is the same thing which I had discussed in the previous slide in a pictorial format. That is, this is the genes in the mitogenic pathway. We know RAS, we know the Pik3 kinase. This is the alpha unit of the Pik3 kinase, which it has the mutations most of the time. This is the downstream mTOR pathway. So this is the mitogenic signaling. The differentiation pathways, which predominantly involve the Notch gene, and then this Notch gene has interactions with other pathways, and the cell cycle disruption and pathways which interfere with apoptosis. So if you look at head and neck squamous carcinomas, what we commonly note is that in the head and neck carcinomas, there is a slight difference in the genomic profile in patients who have HPV positive and HPV negative cancers. If you look at this chart, this shows that significant number of people in the HPV positive group have Pik3ca mutations, FGFR mutations, KMT2D mutations. Whereas if you look at the HPV negative group, they have a large number of people who have TP53 mutations, Notch mutations, cyclin-dependent kinase mutations. And this is partly a difference in the pathways or the genomic alteration seen in these two types of tumors. So what we look at three particular genes for which targets are being developed, and those are, besides Pik3ca, HRAS, and Notch1. And if you look at the proportions, like I discussed in the previous slide, there's a slight difference with Pik3ca being more prominent in HPV positive, but it is also seen in a significantly high number in HPV negative patients, and the Notch1 again seen more in the HPV negative group. So what is the Pik3ca gene? It is the phosphatidylinositol kinase enzyme. So basically, this is an enzyme which is responsible for the addition of a phosphate group to PIP and that converts it to PIP3. And this molecule basically takes part in all the downstream signaling that is in the AKT mTOR pathway or the RAS-RAF pathway. And the alteration in this enzyme leads to a defect, and then that leads to a constitutive activation of downstream signaling pathways. Like you can see here, this is the enzyme which is basically coded for by this gene, and this PIP2 is converted to PIP3 with this enzyme, and this is a regulatory protein that is P85. In general, most cells have some receptor tyrosine kinases which are there, which get activated by a ligand, maybe EGFR, it may be any other ligand that activates the P85 and activates this Pik3ca, and then further downstream pathways are activated. If there's a mutation, these downstream pathways get activated anyway, and then there is cell cycle, cell proliferation, transformations, and other processes in the downstream signaling. This shows the schematic representation of the gene which codes for this, especially this 3CA is the alpha subunit of this enzyme. And this is the part which codes for the P85 binding. This codes for the RAS binding, and these are the helical and the kinase domains of this protein. And these are the hotspot mutations, a lot of mutations seen here, which is marked here. And this is the kinase domain, which is seen commonly in head and neck cancers. So the the Pik3ca pathway doesn't work in isolation. Also, when they have attempted to target it, they have seen that just having a mutation in the pathway alone doesn't indicate for responses with various drugs. But it has been seen that there are a lot of interactions with other genetic mutations seen in head and neck cancers, like the HRAS pathway, which is mutated here, and this interacts with the Pik3 pathway and the AKT pathway. And like we know that the activation mutations in HRAS also play a role in tumorigenesis and inhibition of the HRAS in head and neck cancer. There is a potential target now, which is tipifarnib, which I will discuss later. And the HRAS not only helps in downstream signaling cell growth and transcription, it also has an interaction with the PI3K kinase pathway. Now, the unique thing about RAS inhibitors, we all know they are oncogenes, and in various cancers, the various RASes, that is the KRAS, NRAS, BRAF, and HRAS have been implicated in tumorigenesis. And the basic principle by which they work is there is a particular group, which is a isoprenyl group on the RAS proteins, which take part in all these downstream signalings. And this prenylation occurs by various mechanisms. For HRAS, it is the farnesyl enzyme, that is farnesylation process, which is involved for this prenyl group to be inserted. And tipifarnib blocks this farnesyl transferase enzyme. The HRAS mutation cells are particularly sensitive because this is the only way prenylation occurs, whereas in KRAS and NRAS, there are alternative methods. And this is one of the ways to target the HRAS mutation. So tipifarnib has been published last year in head and neck carcinomas in a small single-arm open-label phase 2 study, where they studied the safety as well as the efficacy in only 22 patients. And they saw an objective response rate of 55% and a median PFS about 5.6%. And they compared it to the PFS to the last therapy, and there the median PFS was 3%. Sorry, not 5.6%, it's 5.6 months and 3.6 months. And this is what they noted, that there was an improvement in the percentage in the number of people with the objective response rate, as well as improvement in the PFS as compared to the last therapy. But however, this was a very small study in a small group of patients of 22 patients with 20 patients who were evaluable for responses. As well as important thing that came through this study is that patients who had HRAS mutation with the high variant allele frequency more than 20, they were the ones who responded to tipifarnib. And they also assessed various dose schedules, that is a lower dose at a continuous intervals, that is 300 milligrams daily, twice a day, or higher doses in shorter intermittent dosing, that is 600 to 900 milligrams on 7 and days 15 to 21 of a 28-day cycle. And this is a study which has now given us some basis to explore tipifarnib further in head and neck squamous cell carcinoma with HRAS mutations. The third important mutation, which is the Notch1 gene mutation, which is mainly for cell differentiation, commonly seen in leukemias. There is also evidence that this plays a role in head and neck squamous carcinoma. And this also has an interaction with the PI3K pathway and the further downstream signaling. So This is a paper published by Vaishnavi Sambandam, who is from the MD Anderson Center, and this was published in 2019. And basically, this paper is a study which explored the efficacy of drugs which inhibit the Notch and the PI3K mTOR pathways in vitro. And what they looked at was, if they added certain drugs that inhibited these PI3K mTOR pathway, and including PI3K as well as the downstream pathway, they looked at the cell lines in which there was a loss of function of Notch mutations. There were PI3K mutations at baseline, PI3K mutations which developed later. And what they found is those who had loss of function in this loss of function Notch mutations, they were sensitive to the various PI3K inhibitors tested in vitro. But they also noted one thing, that just having a basal activation of the PI3K mTOR pathway or HPV positivity did not actually predict sensitivity and to the these drugs which they tested in vitro. However, this is an in vitro study, it is not a clinical study, so more data is required. And this slide represents the same thing. These are patients who were, the drugs were used in various mutations. The bars in red show the ones which have a Notch1 mutation and wild type Pik3ca. And these show the number of cells which had apoptosis, and you can see it's higher in the group with Notch1 mutations. So to summarize briefly, that we know that Pik3ca plays an important role in various cancers. We know it has been studied extensively in breast cancer. Various inhibitors have been used in various trials. So we have also seen that it has a interaction with other mutations in head and neck cancer, like the HRAS and the Notch1 mutations. And probably these mutations like the Notch1 are considered undruggable, but they may provide a basis for targeting the Pik3ca and the downstream mTOR pathway. And mutations in the Notch might be a predictive marker for using these drugs. There's also a study which is planned, which is not yet ongoing, which is planned in the Korean and other subgroups, where they are evaluating a Pik3ca mutation amplification in cohort 1 and or HRAS overexpression by IHC in cohort 2, and they are going to evaluate the combination of tipifarnib, that is an HRAS inhibitor, with alpelisib, which is a Pik3ca inhibitor in this subgroup. This study has to start, and basically the results will be awaited, and this will be interesting. It will provide a basis for further phase 3 studies. So to conclude this segment is that we know that Pik3ca is important. It plays a role in tumorigenesis. It is also inhibition of this Pik3ca has led to an overall objective response rate of 33% in Notch1 mutant HNCC, and these are in preclinical trials. Also, we have a farnesyl transferase inhibitor, tipifarnib, which has been evaluated in phase 2 studies, which has an overall objective response rate of more than 50% in patients with a variant allele frequency of more than 20%. And we know that the HRAS has interactions with the Pik3ca pathway. And studies which are inhibiting both these targets are ongoing, and we are awaiting the results. So the second part of my talk is the role of axitinib in head and neck cancer.
We 2 minutes left, ma'am.
Yeah, we know axitinib is a drug that is studied in RCC. It's an anti-VEGF inhibitor. And the Paul Swisecki, who from the University of Michigan, had actually extensively studied this and published a study previously, which was did not meet its endpoint. But what they noted was that a lot of patients had good survivals with a median of 10.9 months. And then they realized that the RECIST criteria is probably failing to appropriately capture responders, and they planned another study using the CHOI criteria, which is often used in GIST for responses to TKI. And this is what they found in a heavily pretreated population. They have given axitinib 5 milligrams at the starting dose, escalating it to 7 milligrams at 2 weeks and 10 milligrams at 3 weeks in absence of grade 3 or more toxicities. Predominantly, it was a very small phase 2 open label study, predominantly including patients with oropharyngeal cancers, only 2 patients with oral cavity cancers, which is quite different from what we see in our country. Most of the 2/3 of the patients were HPV negative, and a significant number of them had received more than 3 lines of therapy and had platinum refractory disease. And CHOI criteria was basically used to avoid missing out the responses according to RECIST, because CHOI takes into account the tumor or the drug-induced tumor necrosis as well. So This was the treatment efficacy. There was a 6-month PFS, which was 32%. The primary endpoint was a 6-month OS, and they had hypothesized that it should be more than 50%. And in this case, it was 71%, and it met its primary endpoint with a median OS of 9.8 months. And these are the best responses. And you can see that around 36% of patients had a progressive disease, 39 had partial response, and some 4% had a complete response. So this is the overall survival curve. And this is the progression-free survival curve with a median of 3.5 months. And what they interestingly
ma'am, request to conclude, ma'am.
Yeah. So my last slide is to connect this study to what we had previously discussed. What they interestingly saw is that those who had Pik3 signaling pathway alterations, they had a very good response rate, that is 75%. And the second group was the ones with KMT2C and D mutations, which had a 66% response rate. So these again is just the diagrammatic representation. So what these are the toxicities, the common toxicities seen were fatigue, hypertension, mucositis, and diarrhea. Now, what the main conclusion was, the authors concluded that patients who were treated with axitinib, basically which blocked the VEGF pathway, also had an immunomodulatory effect on the tumor cells, and that also predicted better responses in with subsequent therapy. And another important thing that they noted was that Pik3 signaling indicated better responses, that is 75% with non-cutaneous squamous cell carcinoma had responses with Pik3ca signaling. So the exact mechanism is not known, but it is proposed that axitinib might have an impact on this pathway as well. So with this, I'll conclude. Just to summarize my talk, 2 things. Pik3ca signaling is one of the common pathways seen in head and neck squamous cell carcinoma. There are other pathways like HRAS and Notch mutations which interact with Pik3ca and are targets for therapy. And multiple studies are ongoing, and we hope to see some exciting results soon. Axitinib has some promise, which was seen in the study, and more genomic identifications or markers to predict response to axitinib is needed. With this, I'll conclude. Thank you.
Thank you so much, ma'am. I now request Sachin sir to introduce our next speaker.
Yeah, first of all, I would like to thank Dr. Hemant Malhotra sir and Dr. Lalit Mohan Sharma sir for making me part of this 46th icon, and very nice presentation by Dr. Nandini Menon about the Pik3ca pathway and axitinib. And now we are rapidly moving to our second topic that is presented by, it will be presented by Dr. Bharat Vaswani, that is metronomic therapy with MTX and Celecoxib, a boon or a curse in recurrent head and neck cancer. So over to Bharat, sir.
Good evening. Good evening. Am I audible and the slides are visible?
Yes, sir. You're audible and the slides are visible, sir.
Thank you. Thank you, Dr. Hemant sir. Thank you, Dr. Lalit. Thank you, Dr. Sachin. And a special thanks to Dr. Nandini. Sir, ma'am, your group has done the so the topic that I am discussing is in the next 9 minutes is boon or a curse in recurrent head and neck cancer patient. So the first thing is, now when you hear a word boon, what exactly is the word boon? So it's something that is helpful and makes life easier for you. And what is curse? Something that causes harm and evil. And in the next thing, I'll prove that it is a big boon, especially to a low middle countries like India, with giving us an impressive PFS, OS in those who cannot afford immunotherapy and or a targeted therapy. So when we define metronomic therapy, basically a low dose, repeated and regular manner administration of a drug without prolonged drug-free interval. And the basis is giving this low dose drug basically targets endothelial cells in the vasculature of the tumor. So anti-apoptotic and anti-proliferative effect ultimately over a period of time. Now, this is more relevant for a country like India. If you look into a country like India, majority are uninsured, a rural predominant population, and more importantly, the affordability is quite low. So basically, 1 to 3% have access to quality medical care that we all know. The cost of therapy and more importantly, patient living in a faraway area, toxicity management are the primary concerns. Hence, we need an accessible alternative therapy. And answer to the previous 3 things is the best way to treat these patients is having an oral metronomic therapy. We all know that head and neck cancer patient is one of the most common cancer in male and one of the cancer which is rapidly rising in female. So when I talk about metronomic therapy, the bases are simple. A low dose prolonged administration causes anti-angiogenic effect, and celecoxib, probably a more COX-2 expression in head and neck, so ultimately leading to anti-proliferative effect. Also, in addition, a direct cytotoxicity and alteration of local immune milieu. In fact, we are having some trials of immunotherapy now with a thing in the future. So there are two pivotal studies, and both by Tata Group, Kumar Prabhakar and his team. The first was there were a lot of retrospective study, but this was the first prospective study, 110 patient, which was published. Now, what this study first time showed was there was a statistically significant improvement in PFS, 37% reduction in the risk of progression. More importantly, a drug in an oral thing which gives survival close to 8 to 9 months. And the icing on the cake was the lower toxicity. So we had a phase 2 data, but a small phase 2 data. And based on this, Dr. Nandini Menon, my respected previous speaker, presented the main study, which is Metrosis study in ESCO 2020. Kindly look into the doses, 15 mg per meter square per once a week methotrexate. When we give in a triple, it is 9 mg per meter square along with continuous celecoxib. The primary endpoint was overall survival, which I think is the most important. And the other endpoint was toxicity, PFS, and quality of life. Now, when you look into the subtypes of patients, predominant oral cavity, please remember when you look into the other targeted therapy like extreme study, these were lesser numbers. 58% had taken previous treatment and around 48% had relapsed early within 6 months of the previous treatment. Now, when you look into the primary endpoint, 6 months OS, there was around 11.3% improvement as compared to IV cisplatin. So a non-inferiority, in fact, I think it was a slightly superior study, but that non-inferiority for which the trial was conducted satisfied. In terms of quantum of benefit, 1.4 months improvement in OS. Now, when we look into subsets, the more important thing is oral cavity for me. Yes, there was a statistically significant improvement. And for early relapsers also, the hazard ratio was 0.89. So some degree of benefit as compared to non-treatment. Again, a response rate which is acceptable, and twice the PFS. So there was around 50% reduction in the risk of progression when it was compared with IV cisplatin. Most important thing for us is it is a good drug, but more importantly, the toxicity is less. So grade 3 adverse event, if you see, it is less than half. So a statistically significant reduction in the event, grade 3 event, lesser dose reduction, dose interruption, and dose discontinuation. So a good drug, and we can give it up to a patient because if you see the toxicity or the grade 3 or the interruptions are less than 5%. So impressive data. Coming to grade 3 to 5 toxicity, again a data which is impressive. Whatever are the grade 3 to 5 toxicity, if you see the maximum is hyponatremia, other toxicities are less than 5%. So a safer drug with a manageable toxicity with an equally efficacious thing. When we talk about quality of life, again a drug which has maintained or slightly better quality of life in terms of EORTC and head and neck parameters. Now comes the million question that is always being debated about. We have all of other good options. How does oral metronomic therapy compare? So if you look into the data from this with the other data, when you give a cisplatin 5 without any targeted therapy, the survival remains more or less the same, 6.3 to 8.7 months. Now, what is more important is when you look into the cis-5FU arm of extreme study, those patients with the oral cavity had 4.4 months survival. So whether oral cavity, this drug works better or probably we tolerate it better, nobody knows. But more importantly are the two things. A very lesser toxicity as compared to combination therapy, and you can never discuss a cause. This is a cause which is the least among any treatment I can imagine in the world, except for best supportive care. So a safer regime with a lesser toxicity with equal activity. Last two slides of mine. How does this therapy present as ESMO scale or a ESCO scale for clinical benefit? This is also something acceptable for our poor patient who live far away. The ESMO magnitude of clinical scale is 2 and ESCO it is 25.2. So again, when you look into the standard parameters, this is something which is acceptable to all our patients. And if you see in ESMO and ESCO scale also, something which we should accept. A word about triple metronomic therapy, probably what I had is Vijay sir and his team is presenting a phase 3 data here. Probably this is something that I am more impressed. Your response rate goes to 42% in refractory, and more importantly, the disease control rate is very good. your quality of life is very good. So all in all, probably it may add up to what you are giving in 2 drugs, 3 drugs, probably may be better. So the last slide, what is reality in India? I showed you. Now look into the down part of things. Cisplatin even consumes 57% of your family income. You can never discuss pembrolizumab because it consumes 6 months, 100% of your income for many, many years to come. So for me, a drug which has an equivalent efficacy, definitely. So in one word, that was used in editorial in ESCO, money and cents, they had used dollar and cents, reducing physical and financial toxicity. Metronomic therapy is definitely a boon. Absolutely no two thoughts about it as far as the data and more importantly, toxicity and the cost control. So if I have to summarize my presentation, is metronomic therapy a boon or curse? So hands up, it is definitely a boon for all countries, definitely for low middle countries like India, for those patients who cannot afford a targeted therapy and immunotherapy. This is one of the best drugs. There is an ease of administration, oral, accessible to everyone, a better quality of life as compared to IV, and last but not the least is a far lesser side effect. So when we talk about, we have all the 3 parameters we have for a patient: quality, yes; PFS, yes; OS, definitely, yes. So I thank you all for a patient here.
Thank you so much, sir. I now request Ranade sir to please introduce our next speaker.
Thank you, Kashish. Our next speaker is Dr. MV Chandrakanth, and without talking much, I hand it over to him.
I think the slides are visible and I'm audible.
Yes, sir.
Yes, sir, they are.
Okay. Thanks, Ranade sir, for the introduction, and also I would thank the organizers for this opportunity. Today I will discuss a topic which is not much discussed. So we have been hearing about biomarkers for immunotherapy in various cancers, and we will see where does tumor mutation burden and other mutations stand in head and neck cancer. So, well, if you look into this curve, you can see the left upper part. There is a crisscrossing of curves in terms of overall survival. This is the curve. These are the curves of the IPASS study of Ceftinib, where they used never smokers or former smokers who quit as the criteria for choosing patients to expose to Ceftinib. So this sort of crisscrossing happens when we don't have a proper biomarker, or we do not know which population actually benefits with this drug. And you can go to the right upper and the right left lower. The moment you have a proper biomarker like an EGFR, and you can see the crisscrossing disappears. So the crisscrossing happens only if you do not have a proper biomarker to understand which patient benefits and who does not benefit. It is important to know who benefits, and it is more important to know who doesn't benefit, so that the futility of using the drug doesn't exist. And then going on to the pembrolizumab, even if the CPS is more than 1, pembrolizumab versus extreme study, you can see a clear-cut crisscrossing of the curves. Again, even if the PD-L1 is positive, you have 30 to 40% patients progression as the best response, even if CPS is more than 1. That means we are still in the path of searching the best biomarker for immunotherapy. So, well, these are the possible biomarkers we have. We had PD-L1, which is a good biomarker, did show good correlation, especially in lung. And in CPS, you can just see the definitions of CPS, TPS, IC. So CPS is a combined positive score where it includes the PD-L1 staining of tumor cells, lymphocytes, macrophages, all the cells it includes, and the denominator is viable tumor cells. So CPS is sort of a more reliable biomarker in majority of cancers, whether you look in head and neck or whether you look in stomach right now. So CPS is more an impressive biomarker. So we are evolving in finding out a proper biomarker for head and neck cancer and also for other cancers. So these are the biomarkers we have. We have PD-L1, we have TPS, we have CPS. Then we had MSI, which is a very profound biomarker, specific, but unfortunately the percentage is less. Even if you take colon, it is around 3 to 4%. So, but we are missing out, even if the MSI is low and the TMB is high, that proportion of patients also benefit from IO. So probably MSI is not the best way to go. And then we have the tumor mutation burden. So more number of mutations, greater the tumor mutation burden, more neoantigens are there, and it is easily recognizable by the immune cells. Therefore, immunotherapy works better if the TMB is high because of more and more neoantigens. This is the thought process we have. And today in this presentation, I will tell what is TP minus PR score. Just to say, T for tumor mutation burden, and then P for Pik3ca. So if the TMB is high and there is a Pik3ca mutation, it positively correlates with response to immunotherapy. Minus PR, P53 mutation present, and ROS1 mutation present. If these two are present, it negatively indicates response to immunotherapy. Therefore, at the end of this talk, I just want you to remember, if you want to have a potent biomarker for head and neck cancer for immunotherapy, of course, CPS is good, but if you go for further refinement, tumor mutation burden present, and then we must have, if the P53 is absent, ROS is absent, then Pik3ca is present. That means this particular tumor is more responsive. That is a TP minus PR score. So this is the survival we have approximately in head and neck cancer. Extreme is around 10 to 12 months. And if you have keynote in the PD-L1 positive population, it is 12 to 14 months. So if you look into the pembrolizumab trials, the keynote 158, they have used tumor mutation burden and they have found 10 as the mark. So about 10, some sort of predictiveness to immunotherapy, less than 10, less sensitive to immunotherapy. This is what we have. So tumor mutation burden has been the second approved biomarker, pan-cancer biomarker, following MSI. So there is a study saying that in patients where the MSI is low or MSS, in those patients, if the tumor mutation burden is high, they continue to respond to immunotherapy. Okay, so this particular study included 5 cohorts. All these cohorts had exposure to immunotherapy. This included around 120 odd patients. I will just go to the final diagram. You can see around 139 odd patients were there, and it included head and neck cancers of various sites. They were all exposed to immune checkpoint inhibitors. Even ipilimumab was also exposed in few patients. So then they constructed what is known as a TP minus PR score. As I said, these are the abbreviations: TMB, Pik3ca, P53, ROS1. So if TMB is high, Pik3ca present, positive correlation or positive biomarker. If there's high, it is present, it responds well to immunotherapy. P53 negative and ROS1 negative, that means they respond well. So TP minus PR is the score that they used, and they looked into whether this particular scoring prognostic index is better predictive and prognostic with immunotherapy is what they looked at. So they used TMB of 10 as the marker, and they calculated the final score of TP minus PR. So, well, if they looked into the survival probability, you can see if they used tumor mutation burden alone as the marker, the difference was 25 versus 10 months. So looks like significant tumor mutation burden more than 10 predicts good efficacy to immunotherapy. And this is the AUC or the ROC for TNB stratification. And these are other things, again, replicating the same concept, that if there is presence of TP53, that means it doesn't respond well to immunotherapy. Pik3ca mutation present responds well to immunotherapy. ROS1 present doesn't respond to immunotherapy. So TMB, Pik3ca responds well. TP53, ROS1 doesn't respond to immunotherapy. That's what this particular graph says. Again, the same forest plot also you can see TMB and Pik3ca favoring immunotherapy, ROS1, TP53 not favoring immunotherapy. So therefore, the score of TP minus PR, if you can use this particular scoring system and look into the difference in survival, you can see the difference is 25 versus 8 months, more than 3 times difference in overall survival. This sort of difference we have not even seen in PDL1 more than 50%. So looks like TP minus PR being a more sensitive biomarker to pick up patients who benefit, plus picking up patients who do not benefit from immunotherapy. And looking into the ROC, you can see so nicely that this TP minus PR is more predictive of response to immunotherapy than the other existing biomarkers. So the results again depicted there. The limitation was that it did not include HPV as a biomarker in this study. So this study finally concluded that TP minus PR could act as a predictor of efficacy in recurrent metastatic head neck cancer, and patients with high TP minus PR, that is more than 0, had better survival benefit than the patients with low TP minus PR. Almost 3 times difference in overall survival, 8 minus 25 months. And you looked into PDL1 more than 1 or more than 20 or CPS more than 20, this much amount of difference is not seen. If you take only TMB, again the difference is there, but still you are giving immunotherapy to patients who may not benefit. So the authors concluded that to understand which are the patients who actually benefit from immunotherapy in head neck cancer, TP minus PR score, if it is more than 0, then these are the patients who actually benefit from immunotherapy. And if it is less than 0, probably these are the patients we must exclude, and we should not expose these patients to immunotherapy based on the overall survival data of 8 months versus 25 months. So with this, I would conclude my talk, and I would thank everyone for your patient listening. Thank you.
Thank you so much, sir. I now invite Sachin sir to please introduce our moderator and our panelists. Over to you, sir. Ranadi, so can I request you to introduce our moderator?
Yeah, now we'll move on to the panel discussion. And my friend and Professor Kumar Prabhash is going to be the moderator, and I request him to take over. Kumar, please.
Good evening, sir. Thank you for the introduction. We'll go ahead with the panel discussion. Share my slides. Can you see my slides?
Yes, sir, we can see the slides.
So the panelist, we have panelist Dr. Vijay Patil, who is a medical oncologist at Tata Memorial Hospital. Dr. Aparna Shukla, Madam is head radiation oncology at Shalby Hospital, Indore. Dr. Poonam Joshi, Madam is surgical oncologist, head and neck surgeon at Tata Memorial Hospital. Dr. Chakor Vora, medical oncologist at Pune. And Dr. Arvind Krishnamurthy, he is the head surgical oncologist at Chennai Adyar. Dr. N. Prem, he is a geriatric medicine specialist, and really a relatively new area which is upcoming and we require more at Jaslok Hospital. Dr. Narendra Padiyar, he is principal and dean Mahatma Gandhi Dental College, Jaipur. And Dr. Nipun Lamba, he is associate professor of pain and palliative medicine at Mahatma Gandhi Medical College, Jaipur. So we have a very good panel with all mixture of palliative care to surgical oncologist, and the topic is also a bit atypical, and the topic is buccal mucosa management of relapse after first line palliative chemo. So that became a pretty specific topic. So what I'll try to do is, this is uncommon topic to be discussed, but as the second line, that is after relapse, it depends upon what you do in first line. We'll also talk a bit about first line, a little bit, and then we'll talk about, we do have a good mix of surgical and radiation oncologists. Why in second line? Today we are talking about local treatment. So starting with Dr. Vijay. Vijay, why we are talking about local treatment in second line setting? Do you think 2 years or 5 years back we were talking about it?
I don't think so, sir. I think the interest in local treatment in second line is specifically because of the good results which we are getting with the current immunotherapy drugs. We are looking at 3 years, 4 years outcomes, especially in patients greater than CPS score of 50 of quite long. And I think that is the reason why there is a renewed interest in looking at local treatment in second line setting.
I think so, Vijay, you are spot on that as the disease biology changes, either the biology changes like the way it has happened in HPV, or because of treatment, it starts changing. And the outcome starts changing, the treatment to planning and what we plan for patients start changing. And this is one of them. But I do agree that I didn't think this topic will be discussed too early, but I think so it will be discussed more and more in due course. So coming to Dr. Arvind Krishnamurthy, Arvind, this is for in general for the recurrent tumor that the patients which we used to choose for local treatment. Does the similar criteria stands true for second line therapy for treating the patient with surgery?
Well, I can say for the first relapse, yes. But for the second relapse, I think one must be very highly selective about treating these patients. And generally, I think as a ballpark, what we tend to see some criteria. And one criteria was the first and most important criteria is what prior treatments the patient has received. That is one important aspect. The other aspect is whether, of course, the disease per se is actually amenable for any of these resections. The other issue is the performance status of the patient. And also the many other issues will be, of course, the sense whether the patient will be able to tolerate. Again, it's a question of performance status for these patients. Yeah, and the concept of oligometastatic, of course, has been there in many other cancers. Head and neck, I'm not really sure how much it is there, but I guess, if you sort of, choose for selected patients, I guess you may be able to get in the second line also about 5-year survivals anywhere ranging from 15 to 30%, but not as much as compared to many other solid tumors like possibly breast cancers, for example.
So taking this question a bit further, so second, and I agree with you. I was also trying to scratch my head when Pankaj or Prathamesh has operated on second line. But yes, it was interesting question. So I think about giving nivolumab to the patient, and that patient tumor has shrunk, not completely, but remained for 2 years, and it is T2 lesion. It was T4 earlier, but now it is T2. Theoretically, that's the only clone left. For example, germ cell tumor, not exactly the same. Do you tempted to remove it?
No, again, Kumar, it's a question of also disease-free interval, or how the trajectory of the disease has behaved over a period of time. I guess there is no straightforward answer for it. We possibly sort of observe these patients, the trajectory of the disease over time, and if the disease is sort of biologically quiescent, I'm sure that there is no definition per se to say 1 year or 2 years or something of that sort. It's
I just put a ballpark figure, but it will be tempted. Do you think that you'll be tempted? Because once in a while we have come to this situation. Unfortunately, that other patient was with Devendra was treating, but it was a complete response, so we didn't have an answer to the patient. But if there is residual,
yeah, I think very choosy, and we can sort of select. We were very highly selective. It's not very uncommon in our practice, but I guess that odd exceptional responder patients whose disease has been quiescent for a reasonable period of time, let me put it that way, we may be tempted to consider some form of local treatment.
So let me take this question to Dr. Poonam. Poonam, as Dr. Arvind said, it is uncommon. It will remain relatively uncommon, but with immunotherapy, we will have almost, maybe not in first line, but second line, we will have those 10 to 15% of the patient where they will be having a sustained response. And in Indian context, we are not giving immunotherapy much. In 2 years down the line, when we have generic, then we will have these numbers those 10% will become a good number in the clinic. So when you will be tempted, to remove that residual tumor?
Correct, sir. So, like you rightly said that over the years or down the line, we probably are going to have more number of patients which will be planning for surgery. So, as a surgeon, if I have to decide that which patients can be resected post relapse, or I would say residual tumor after first line of chemotherapy or the immunotherapy, I think, sir, here 2 points will be important. One would be that is the disease localized? We are talking about CA buccal mucosa specifically. We are not talking about other head and neck sites because that changes the management further. So when we are talking about buccal mucosa cancers, if we know that most of the cancers, they recur locally or regionally. So if though there can be distal mets also. So if the disease is in a local or regional place, and like Arvind sir earlier said, that if the disease-free interval is going to be an important predictor for that. So, so if the disease-free interval is at least 2 years, like there are a lot of studies which have shown if the disease-free interval is 2 years or more, then usually the response rates are better. Other thing which we will have to see is naturally the performance status of the patient, how much the patient has been treated earlier. And I think one more important point is that what kind of already organ dysfunction this patient has. So that is, and the other point would be that what will be the life expectancy of this patient? Because as we know, these patients have so much of these, we saw in the previous discussion also, they have high tumor mutational burden and they have a poor genetic profile. Even they are more unregulated than the regular tumors. So naturally, their prognosis is going to be bad, and over the years probably will be seen. So that will be for the local disease. Same will apply for the lung metastasis also, because that again, because there is some data to suggest that probably if we can do for single or oligometastatic lesions in the lung, the survival can reach up to 30 to 40%. The recent series from Japan has published that. But few of those patients, they have given even immunotherapy after that. So I think those same points, patient factors, tumor factors, previous treatment, these will define that are we going to treat this patient with surgery or not.
Kumar, just to add to what Poonam also said, and these are the thoughts that just came to my mind right now. One another aspect would be to achieve an R0 resection. Then only possibly we would sort of embark on this. If we are going to cut through tumor or or not do in that way, then we would definitely not embark on this adventure of sorts. Yeah.
Agree with you. So in fact, I was having a discussion in day for yesterday in the JC, and we were talking about esophageal cancer, and my RT colleague was teasing my surgeon that with chemoradiation we'll be treating most of the squamous cell. So I interjected, hey, they'll be treating many more metastatic disease in future, when you have those residuals. So the way treatment changes our approach to how we manage patient. So we'll come to our radiation oncology colleagues, Dr. Arpana Shukla. Madam, we know that first recurrence surgery, that is the where you are very comfortable giving RT, and I think so that is where it acts maximum. In second time, residual disease or after surgery, where you are more comfortable, and any your thought process on immunological modulation for radiotherapy with immunotherapy, because at this moment I can only see immunotherapy in head and neck cancer, which can make these kind of differences and bring in multiple modality in the treatment in these advanced disease. Yes, ma'am.
Yeah. So loco-regional cancer, regional recurrence is still the challenging task for any oncologist, and it needs to be discussed in multidisciplinary team. And as already discussed, we have to consider the site and stage of first primary disease, prior treatment, tolerance to the treatment, disease-free interval, and the accessibility. And as far as re-radiation is considered, now we have various advancement in the techniques. So we have various options. So whenever it is indicated after surgery, we should go ahead for it. And I would like to say we are talking of failure after second-line chemo. So it's a palliative setting. Sometimes radiation can be used for palliation also if there is an impending fungation or something in along with the second or third line chemotherapy. And it can also be used in radical dose in re-radiation setting also if it fulfills all the criteria. So there are options available now.
So again, hearing from our radiation oncology colleague, till recently, once RT, it was done. Then we used to wait for years where we can think about giving RT. We are thinking of giving more than once. Not only that, if there are residuals, if there are oligo progression, there's the oligo, metastatic disease, we want to have, those local treatment to be applied. Coming to systemic therapy, Dr. Chakor, what are the options and how do you choose them?
Sir, Dr. Chakor couldn't join us, sir.
No issue. Vijay, what are the options? And we heard two very nice lectures, and some of the data for me also was revealing. Do they come to your mind? And some of the drugs are easily available out of them.
Options for second line, na, sir?
Yeah, second line. So beyond the usual one, that also you should talk about, but beyond you heard in the talk.
So when I look at a patient who is for a second line recurrent head and neck squamous cell carcinoma, my first thing is to see whether it is platinum sensitive or platinum refractory. Most of the time, this will be platinum refractory.
Maybe you want to clarify for the audience when we say second line. Yes. How do we define so that they can pick up those patients? For example, patient after chemo radiation relapsing within 1 or 2 months, where they fit in.
Yeah, so what we're talking about is like patients if he has received chemotherapy, especially cisplatin, as a part of curative treatment modality, either as a concurrent chemo during radiation, or either as a neoadjuvant chemotherapy, and if the patient fails within 6 months of the last dose of cisplatin, then that would be considered as cisplatin refractory, or if carboplatin is given, then that's platinum refractory. So the failure within 6 months of the last dose of platinum would be the definition for platinum refractory. And these patients traditionally are then to be considered at present the drugs which work in this are nivolumab.
Vijay, can I interject? So yeah. So if for the audience sake, if we say that if your patients relapsing within 6 months, consider them like a second line. Am I right?
Yeah. You consider
them. Go ahead, Vijay.
So in that situation, you treat them with either pembrolizumab or nivolumab if patient can be affording. If patient is not affording, there is also an option of triple metronomic chemotherapy. If in this patients, I also do as this is recommended even in NCCN, I would get a NGS done for these patients to look for any driver mutations if they are there, especially when you're talking about buccal mucosa. I would be looking at HRAS or NTRK expressions if they are there. Would also be looking at if there is some amount of microsatellite instability, if it is there, because if microsatellite instability comes, then the treatment with pembrolizumab gives a lot of benefit in this situation. HRAS, as we all know, would come in around 6% of patients of oral cancers taking buccal and tongue together. So you may get, we don't have Indian data, how many patients in India would have HRAS positivity, but tipifarnib is an option in these patients, and I think it gives a response rate is in the range of 50%, if I'm not mistaken, with this drug. So those are the options which come to my mind when I look at these patients.
Okay. But HRAS, we had our oral cavity data around 14% from Dr. Dutt's lab.
Yeah. We had that data. Yes, it will be around 14%. That's correct. Yeah.
Not less. So one needs to think about it if one wants to try that. And now it's available on compassionate basis. Again, for the audience sake, in case people want to explore. Vijay, any data for axitinib, was it exciting for you?
Actually, it was not much exciting for me. That's
not exciting for you.
Yeah, it was not much exciting for me.
It was 9.8 months median survival, second line.
Yeah.
Okay.
I
You want to
would
combine
trust,
with something.
yeah, I would trust triple metronomic more than for a patient.
There is a lot of work on axitinib plus immunotherapy.
Yeah.
Does that strike something? No.
No, sir, it doesn't strike me.
Does that strike? No issue. So I think so. What Vijay expressed, that when you get into second line, the way it was, we didn't have any option earlier. We may use one of the whatever is available, some docetaxel or afatinib or some other treatment. That is not the case here. Now you do have option. You have immunotherapy in case you have not used earlier. You do have triple metronomic. You do have genomics, which may help you getting some drugs which is available. One needs to choose them depending upon what patient has done earlier and which situation the patient is in. We will take the next situation and question to Dr. Nipun Lamba. Early palliative care, when to implement, how to implement, and how useful it is.
Sir, thank you very much for giving me the opportunity. Sir, palliative care is very important when we are talking about CA buccal mucosa, because we are managing even pain of the patient in a very good way, sir. In patients who are receiving radiation, even after first-line therapy or early palliative care. So patients are complaining of severe pain. We have performed a study, we are performing it presently, in which we are giving sphenopalatine ganglion blocks through intranasal approach as well as through coronoid approach fluoroscopically. And these procedures have shown to be drastically reduce pain in many of the patients. So the journey of radiation becomes very less painful for the person if we start integrate palliative care earlier. And it has been proven very useful in many of our patients, sir. Also, sir, we have seen that patients have become more compliant. They were able to complete the necessary radiation and the treatment. And even doses of morphine has also been reduced in many of the patients who are receiving early palliative care.
So thank you for your comment, Dr. Lamba.
So
Vijay,
5 minutes left, sir.
How much?
So 5 minutes left, sir.
Okay, we'll finish before that. Vijay, you want to comment on early palliative care and its implementation and issues?
So early palliative care overall, and we all know about the Tamil paper which came in lung cancer in 2010 in New England Journal of Medicine, when it did show that addition of early palliative care led to not only an improvement in quality of life, improvement in symptom index of the patient, but also an improvement in survival. We actually did a phase 3 study at Tata in which we offered early palliative care to half of a patient in a randomized setting. Unfortunately, in our setup, it turned out that early palliative care didn't lead to an improvement in quality of life of the patient, neither improved the outcomes. But there was a catch here that most of the our team who worked on the medical oncology side all had basic training in palliative care. So the basic aspects of palliative care, which is giving good pain control with using morphine more frequently, doing counseling of the patient, doing distress screening of the patient, helping the patient with financial need, helping the patient with appointments, which are basically jobs which were done in the early palliative care arm in the Tamil paper were done by both of us, but by the physicians also and by the palliative care experts also. So I think that was probably the reason why in our study it did not show a difference. But overall, there's overwhelming data that palliative care helps patient, and early introduction of palliative care definitely helps patients in not only in improving quality of life, survival, but also taking good decisions regarding their end of life care and whether they want to get hospitalized and whether they want any ventilator supports or not. So it's important to have those discussions upfront with the patient.
So may I add?
Go ahead, Nipun.
Sir, actually, what sir is saying, this has also been said in other research studies also. But sir, the main thing which I found difference in our center was, sir, when we are performing sphenopalatine ganglion blocks in these patients, then the scenario changes, sir. When we are relying only on medicines for palliative care and counseling, then compliance of patient for radiation changes. But if we are giving a sphenopalatine ganglion block, even intranasally, which is a non-invasive approach, on regular days for 4 to 5 days, we have seen that patients who were drop out from radiation treatment, they were able to complete the radiation treatment and there were better results. And sir, we have seen very wonderful results, and we are going to publish a paper on that also, that when we provide good pain relief in these patients, then the early palliative care leads to very good outcome in these patients.
Agree with you, Dr. Nipun. In fact, Nipun, Vijay was saying the same thing. What he was suggesting that in this our study, which was a phase 3 study, and this was the only phase 3 study, the head and neck cancer was a negative one. But having said that, this also makes us realize that negative study doesn't mean that modality what we are using, that is bad. I think so. The way we are today evaluating palliative care is a challenge. And this is again another paper of ours, which I didn't bring it because of the time we have. Distress management, which is part of the palliative care, it makes a difference. So early palliative care has many components. In many patients, the different components are very important. Somehow, when the moment we evaluate all components in one go, we start seeing that outcome may not look good, but that's not true. And what you said is important. If there is pain, and if you are able to remove the pain by blocking the ganglion, that will sure lead to dramatic relief in the patient. So that's what also Vijay was trying to highlight. Am I rightly concluding, Vijay? Yes. For our paper, both the papers which I mentioned?
Yes, sir. Yes, sir.
So coming to last two questions, one for geriatric medicine, which we can't get away in today's time without talking about almost in any scenario. Dr. N.N. Prem, Dr. Prem, geriatric medicine. How do we sensitize the clinician that this is important, and every patient who is in geriatric age group needs to be evaluated, especially for their frailty and the different aspects of frailty. Dr. Prem is there?
Yes, thank you. Thank you, Dr. Kumar. And yeah, thanks for the organizers to get me on this panel. I think as I was hearing the entire way, we were talking about performance status. So I think, I mean, it's very well established even in most of the research which has gone that if you do a comprehensive geriatric assessment, it's a better way of knowing the functional status, especially because the elder's health is dependent not only on the performance status per se, but on a lot of things. There is a lot of comorbidity burden, there is a cognitive domain, there is obviously a presence absence of depression, and there are some things obviously known as geriatric syndromes, and sir obviously said about frailty as well. So if an assessment, as in case of palliative care, yes, is an assessment is done earlier itself, we are obviously able to know through scales and to predict whether they would obviously tolerate it better or not. This would obviously help us in getting the overall health of that older adult rather than only thinking of the particular cancer that we have to actually treat. And it helps, it only is a great add-on to geriatric oncology purely because an oncologist already looks in such great detail. But I think the aspect of the cancer, and apart from that, the comorbidity burden and quality of life is something which is easily judged with the comprehensive geriatric assessment. And I think it's very much a necessity in which we will be able to get a better outline on what the overall health status is, and so that the treatment obviously can change accordingly, and we can decide upon various modalities as the geriatric assessment obviously changes, which can be very fluid as the health worsens.
So what Dr. Prem is trying to convey that many times, not many times, most of the times we see performance status and comorbidities and evaluate the patient for our therapy decision making. It is important that we use geriatric assessment because it looks like they evaluate the patient groupings for different treatment. The way they can tolerate is far better, and that will help in patient care. Last, my question and experience sharing from Dr. Narendra Padiyar. Sir, your take on head and neck cancer management over a few decades, how it looks like, and when we used to think so tough to treat big tumors with big flaps coming in, better treatment came in, better radiotherapy machines, better tolerance to the patient, came in now. You have some promising systemic therapy where we are talking not only first line. When I started my practice, first line systemic therapy were questioned that should we give it in patient or not in head and neck cancer in palliative setting, and we are talking second line and beyond. Any
So
comment by?
Yes, sir. First of all, thank you for giving me an opportunity. But I'm not sure whether I can answer your question, as such, because my background is I'm a prosthodontist. I'm a, I mean, it's an educative session for me, more so. But one thing I would say is, considering CA buccal mucosa and the topic we are in, we are focusing mainly on, the survival of the patient as a priority. And what, from the dental perspective, what I can say is, probably in the early stages of the disease, the dental team can definitely make things better for the patient, improving quality of life by rehabilitating his masticatory performance. But considering the discussion we are in, I don't know how much the dental professional as a prosthodontist we can contribute to his improvement in his quality of life, because we are basically would love to rehabilitate his masticatory function, because it's not only the curative part or even just curing him of the disease, or even give him a chance to live, but we focus mainly on improving his mastication and also quality of life. That's all I can add here, because I cannot give a perspective. I'm really sorry.
No issue. So I think so it will all depend upon how much Dr. Poonam and Dr. Arvind is willing to cut. More they are willing to be cut, more you will be willing to reconstruct those dental part of it.
Reconstruction comes at a huge cost, and considering the survival rates we are looking at, I don't think it can be a option for most of the patients.
So I do agree with in principle, but believe me, it was a surprise for me also that that 15 years down the line, I'll be talking about second line treatment in head and neck cancer. I didn't think about it. I'll give you another example.
Yeah.
Prostate cancer being chemosensitive, I never thought. But it was taught to us that prostate cancer is not chemosensitive. And now, there's one drug called docetaxel, which we use in head and neck also. That drug works, has got one of the best results in prostate cancer. And this was our teaching. You have many of the medical oncologists here. They will vouch for me, for my age group, not the younger one. Younger one has seen those results. So you may be for surprise, sir. Your services may be required sooner than later. Coming to the end of the discussion, any other comment by any other panelist?
Sir, can I answer this last question? Not answer, like I can just tell my experience, because I think I also have experience of last 12, 13 years. So I think we have seen that in these last decade at least, that earlier we used to think that, okay, the recurrence, once recurrence or a metastatic disease is there, it is going to be the end of the life. So we used to say that the median survival is going to be 3 to 6 months. But as the time has progressed and the new targeted therapies and moreover the immunological therapies have come into picture, we have seen that even now we are talking about the median survival. I think the previous presentation by Dr. Nandini, that even with the axitinib, which is a multikinase inhibitor, with I think immunotherapy, the survival in these heavily previously treated patients also have around 10 months of median survival. So I think we have come a long way from 3 to 6 month median survival to a patient where the second line chemotherapy or the immunotherapy is giving a median survival of 10 months. I think there are new pathways which are evolving, and with the coming years, we are going to have further these therapies for these molecular pathways. I think we have evolved a lot.
Thank you. Thank you, Dr. Poonam. Any other last comment by anyone? Just adding to Dr. Poonam, what Dr. Poonam said, if you give first line therapy with immunotherapy, with chemotherapy, 4 years survival is around 30%, and not a great one. It's 70% people do die at 4 years, but I didn't think it around 10 years back it's possible. Yeah. Anyone else? Any last comment by anyone?
Sir, apologies, we're running short of time.
Okay. Thank you. Thank you so much. I thank the organizer and especially our panelists for a wonderful discussion. Thank you so much.
Thank you so much, sir. Due to want of time, we'll move on to the next session. Thank you to all the chairpersons, to our panelists, to speakers, and of course, our brilliant moderator. We'll move on to our next session. This session is on CNS cancer, and it gives me great pleasure to introduce our two session directors, Dr. D.P. Singh, who's a senior professor and head of Department of Radiation Oncology at Mahatma Gandhi Medical College and Hospital, Jaipur, and Dr. R.K. Tanwar, senior professor, Radiation Oncology at Government Medical College, Kota. Over to you, sir. Sir, I request you to introduce our chairpersons for the evening.
Hello, Dr.
Yes, sir. Please go ahead, sir.
Dr. Nandini Menon, who is a chairperson.
So I invite our chairpersons, Dr. Nidhi Patni, who's the Director, Department of Radiation Oncologist at Bhagwan Mahavir Cancer Hospital and Research Center, Jaipur. And our second chairperson is Dr. Shantanu Sharma, Professor of Radiation Oncology at SMS Medical College and the attached hospitals at Jaipur. So Nidhi ma'am, I request you to please introduce our first speaker. Over to you, ma'am.
Our first speaker is none other than Dr. Rakesh Jalali, who is actually a synonymous with CNS tumors over the last few years in India since he had moved from Royal Marsden. And I'm fortunate to have had worked with him at Tata Memorial Hospital. Without wasting any more time, over to you, Dr. Jalali, sir.
Thanks very much, Dr. Nidhi, and I begin by expressing my gratitude to Dr. Malhotra, Dr. Lalit Mohan Sharma, a lot of friends I could see in this wonderful meeting. It's a pleasure to be participating in this today's forum. I've been asked to speak on role of proton therapy in brain tumors, and I just begin by showing you the American Society of Radiation Oncology, the ASTRO guidelines, which have classified different indications depending upon the level of evidence that we have. And as you can readily see, the group 1 are the group of patients where there is a fairly robust evidence, including ocular tumor, skull-based, children, but also you will notice the malignant and benign primary CNS tumors do form into the group 1 indications. Group 2 are where still the evidence is mounting. Almost all the pediatric consensus groups throughout the globe have moved away from photon to proton in vast majority of childhood cancers, including brain tumors in kids, which forms a considerable amount of population. It's been estimated in the next 10, 12 years, 20-25% of all irradiated patients could potentially be suitable for proton therapy. We are fortunate that the proton therapy facility in India started more than 3 years ago now in Chennai, and very soon we will have another facility in Mumbai and Tata Memorial. Is a great opportunity for all the patients in this part of the world, as well as the doctors and physicians and oncologists to participate and to deliver this kind of treatment. We started humbly with about 7 to 8 patients a day. That's how the proton world works. It's a fairly intense physical and technological advance and needs a lots of QA, several folds as compared to a conventional photon radiation. But in the last 2 or 3 months now, we are able to treat 40 to 45 patients a day on 3 rooms with 16-hour schedule. It's a small waiting list, but we are managing to treat a fair number of patients on the gantries. The Proton Cancer Center facility here in Chennai, which I overlook, also has a dedicated comprehensive cancer center, and the care is given by cancer management teams akin to DMG concept in Tata Memorial, and we have 7 or 8 CMTs, site-specific multidisciplinary tumor boards, and as you would expect in any other major cancer center. We have actually treated now more than 560 patients, and a good proportion of these patients do comprise neuro patients, with very young to very old patients comprising the different patient setup. Our first series was published in children and young adults in JCO's Global Oncology, ranging primarily to the AYA population, comprising of several types of brain tumors, and was essentially to gauge the first audit of how we are doing in a different range of pediatric patients, and which also comprised a fair number of brain tumors. We have just published last month
a commentary on, because many people have questioned that in LMICs, is the need justified, as is true with any major oncology program, be it immunotherapy, targeted therapy, NGS, robotics. We have given a fair amount of commentary as to why it is needed in countries like ours as well. And we are grateful to JCO's Global Oncology to have accepted our piece. The classic indication of skull-based tumors has long been demonstrated to benefit from proton therapy, particularly with the advent of pencil beam IMPT, image-guided intensity modulated proton therapy, with otherwise very difficult tumors to treat. You have to give very, very high doses of more than 72 to 74 gray to achieve outcomes like 80% in chordomas and about 90% in chondrosarcomas. This was implemented in our setup as well, initially with a small case series, and now we also developed several models from physics point of view, one of which was actually published in prestigious Physics and Medicine and Biology. Is not easy to publish there, and the dictum being 72 cobalt gray equivalent in our cohort of patients. We are fortunate and blessed to have an amazing skull-based team comprising head and neck and neurosurgeons. Sometimes the patients come like this. The brainstem dose is very, very important. This patient, for example, was earlier operated upon, received gamma knife, but the recurrences were there with chordoma, which we know recurrences will take place if you do only focused radiation. It is a non-contiguous spread. Our skull-based team could manage to remove this tumor from the brainstem. 30% of skull-based chordoma in our series actually underwent surgery, first time, to give us the benefit from optic apparatus compression and brainstem compression, and then we can achieve very good dose distribution. In our first cohort of 40-odd patients, they have done very well with the 3-tier doses of low-dose CTV of 56 to 64, tier 2 70.4, and try to do 72.6, which is EQ2 of 76 gray. At a relatively short follow-up, of course, the local control is extremely encouraging, but we have to wait for a few more years to have the confidence that indeed it is the case in long term. These are some of the dose prescription levels which we managed to do with the optimization on the race station with the pencil beam technology. Craniopharyngioma, again, a very good tumor to treat because you can spare the hippocampus. Based on our data in Tata Memorial, the hippocampus dose is extremely important, and here we are able to demonstrate a fantastic reduction of the doses to the temporal lobe, frontal lobe, brainstem, optic apparatus, and so on and so forth. We have to be very careful in proton though, because it's any density can perturb the dose. So the cyst volume is carefully very seen, and we have also witnessed dramatic shrinkage of the cyst, which I was not witnessing so much in photon world. In proton, somehow we are seeing good shrinkage, and that manuscript is under review at the moment as well. Again, very good data so far, about 100%, but we again have to wait for a little bit more time. One of our good cohort of patients is actually craniospinal radiation medulloblastoma with molecular profiling, both adults and pediatrics. Some of the early data was already published. We have now 40 odd more patients at a median follow-up of doing extremely well. 95% are alive in the medulloblastoma group, and we are able to reduce the doses to extremely low level to the lens, parotid, lung, kidney, heart, bowel, which is much, much better than any photon technology. And this is the first report from India, is again manuscript under review, and hopefully will be published very soon for the international literature. Ependymomas, again, very good indications. Our youngest child has been treated to be 12 months, which age is no longer a criteria, with the focal RT in the posterior fossa A type, but also in the recurrent setting, especially if they have 1Q gain, we are increasingly using CSI because proton is a beautiful technology for CSI, and again, very encouraging data in the ependymomas. Intracranial germ cell tumors, both germinoma and non-germinomatous, where you can spare the adjacent temporal lobes and hippocampus. Some of the data is very encouraging. First series was already published earlier this year. Last year in Indian Pediatrics, this girl is a good demonstration of full hair growth, good height so far, and very good, academically, she did very well in her exams, and we hope that she continues to do well in the long term as well. And finally, one or two slides that the long-term side effects have been well demonstrated, not only to the second cancer risk, but also the lower doses to the cochlea, to the heart, and to the many other long-term effects which are otherwise a problem in childhood brain tumors. Atypical meningiomas, and anaplastic meningiomas and all sorts of difficult cases that we see. You can see very good response. This was an NF2 with acoustic neuroma, also see necrosis and large meningiomatosis can be able to treat in a large volume with the proton beam therapy. Low-grade gliomas, particularly pylocytic astrocytomas, can be also dealt with very well. The non-going randomized trial in the US is comparing with cognition as an endpoint in this cohort of patients as well. We have been meticulously collecting patient-reported outcomes at the baseline and in follow-up using very good parameters, validated parameters, both for brain tumors as well as other sites. And again, so far the results have been encouraging. There are other sets of papers which are out there already with more than 7 to 10 years follow-up demonstrating the preserved cognition, preserved endocrine function, and very good quality of life in this type of patients. My last slide is on glioblastoma because that itself is a very difficult disease. But in other sites, for example, esophagus, there is also tons of data available from medical oncology. The ratio of lymphopenia being such an important criteria for long-term survival. So it has been demonstrated not only the temozolomide in GBM, but the volume of radiation which can be further reduced by proton therapy potentially could have some benefit in glioblastoma as well. So we are not treating routinely GBM, but in molecularly favorable, young with good resection, especially large tumors, as per the current clinical trial being done in the US in BN001, hopefully in GBM also in some due time. This is our experience, which we are presenting next month in WFNS on the low-grade gliomas, the high-grade gliomas as well of 61 patients consecutively treated and also ependymomas. Hopefully in this set of patients also there might be some benefit in this difficult to treat otherwise patients. With that, I thank all the members of our team, our patients, our referring doctors, foremost our patients and their families, and of course all of you and the organizers for your patient listening. Thank you.
Thank you so much, sir. Thank you for the wonderful presentation. We'll move on to our next session. I now invite Dr. Shantanu Sharma to please introduce our moderator and our panelists. Over to you, sir.
Hi, good evening.
Good evening, sir. Sir, if I can request Dr. DP Singh to please introduce our moderator. Sir, you'll have to unmute your mic, sir. Dr. DP Singh. Sophia, can you go to the previous slide? So it gives me great pleasure to introduce our moderator, Dr. T. Raja, who is the Director of Medical Oncology at Apollo Cancer Center, Chennai. His panelists that have logged in are Dr. Venkatraman Radhakrishnan, who is a Professor and Head of Department Medical Oncology, Cancer Institute, Adyar, Chennai. Dr. Ashish Singh, Professor and Head Department of Medical Oncology, Christian Medical College, Vellore. Dr. Pooja Nandwani Patel, Senior Consultant and Head, Department of Radiation Oncology, Sterling Cancer Hospital, Ahmedabad. Dr. Tejpal Gupta, Professor and Consultant, Radiation Oncologist, TMC, Mumbai. And thank you to Govind sir, who has agreed to also be part of the panel. He's a medical oncologist and professor at HCG, Bangalore. Over to you, sir.
Kashish, did you say Dr. Govind? Dr. Govind Babu.
Yes, sir. Govind sir has agreed to be a part of the panel.
So our panelists here are Amit, Venkatraman, Bharat, Ashish, Pooja, Tejpal, and Dr. Govind, correct?
So Dr. Bharat will not be able to log in. Dr. Amit and Dr. Ashish will log in soon, sir.
Fine. Thank you. Thank you for this wonderful opportunity. And it's very difficult to talk after, our Dr. Rakesh has spoken. So after nobody would want to speak after Rakesh. Hi, good evening, Rakesh. A fantastic lecture. I was just enjoying your lecture actually. So good evening. Let me get on with my panel here. Allow me to put my screen here. Just give me a minute. I'm so sorry. Just give me a minute. So my slides are visible. I'm okay.
Yes, sir. The slides are visible, sir.
Thank you. Thank you.
Raja, can see your slides, colorful.
Thank you. Thank you so much, sir. And real pleasure, honor, and apologies for slight delay. I'll get going with my panelists. And the brief is to talk about, whether we are really making a difference. Lung cancer, breast cancer, CNS metastasis, with all that we know so far. That's the deal. So let's see what we can bring out of our panelists. I will ask, I'll go with Dr. Venkatraman Radhakrishnan. He's a professor from the Premier Institute. Venkat, CNS metastasis in lung cancer, quickly speaking, 30% incidence in CNS metastasis. And we know that certain lung cancers, particularly the EGFR-driven one, so on and so forth, ALK, they have a higher incidence of CNS metastasis. And then if you take the breast cancer again, lung, and then the biggest burden is breast, and you see that again, nearly 10 to 20% of them eventually have brain metastasis. That's what we see. And we know that it's a bad disease. What's the kind of clinical burden that we see in brain mets with breast and lung? Dr. Venkat, in your opinion?
Thank you, sir, for the opportunity. In lung, we see about 10 to 15% of the patients who present with symptomatic brain mets. We detect about another 20% of patients on routine MRI, because we routinely do MRIs for all metastatic lung cancer patients, another 20%. In breast cancer, de novo brain mets is rare. We tend to see them mostly in patients who relapse after getting treatment for breast cancer. Probably about 5% of our breast cancer patients, but we see more lung cancer patients with brain mets than breast cancer patients.
Okay, so that's fine. So that's the clinical relevance. Big diseases, and then there's a big burden of brain secondaries. That's exactly why we are worried about it. So now we'll talk about the risk factors. Is there any way we can start guessing whether such a patient is going to develop brain metastasis? Will there be a brain met and so on? Sometimes it's easy, sometimes it's not easy. So I'm just quickly profiling how to identify the risk factors for brain mets. And then that will have implications, which patient I will do, as you mentioned, surveillance or compulsory scan, so on and so forth. For breast cancer, if you look at this is a paper in Asian Journal of Surgery and by Dr. Chow et al. And basically high histological grade, estrogen receptor negative. And so these were the factors, when we look at why it would be. And then going a little deeper into breast, this is incidence pattern prognosis in triple negative breast cancer. Everybody knows that has the highest incidence, and next comes the HER2 breast cancer. And we know that among the lung cancers, certain groups of lung cancer. So how do we look at the risk for Dr. Ashish, if you can take the question, risk factors for developing brain mets, so that we can be really alert and do something different?
Yes, sir. So as you pointed out, risk factors, one is the disease per se. Some diseases have a very high baseline predilection itself. Like, for example, if you take melanomas, or if you take small cell lung cancers. And then there is a second group of patients where we have good systemic therapy, and those good systemic therapies ensure that these patients live longer, and then CNS manifest as a sanctuary site. So many of our patients with ALK positive lung cancer, even EGFR positive, or even HER2 positive breast cancers. And so that is where you have excellent treatment for systemic therapy, but later on they worsen, they manifest with CNS disease.
Yeah, thanks, Dr. Ashish. So I'm going to throw an interesting curveball here. I'm going to ask Dr. Dr. Pooja. Dr. Pooja, you are here. Good evening. My question is organotrophism, and what is organotrophism, and whether that can explain the reason why certain patients develop mets. So your comment on that, Dr. Pooja? Dr. Amit, if you are there.
Pooja ma'am, you'll have to unmute your mic, ma'am.
Can you please? Yeah.
Hello, am I audible?
Yes, Dr. Pooja, you are audible.
Good evening, sir. So at the outset, first of all,
Basically, let me not tear. Let's organotrophism is basically because why certain tumors, certain breast cancers or certain lung cancer, that's the deal here, find the way to the breast, and so they have a predilection. That's what is organotrophism, and we can deep dive and finally figure out that there are some special expression of CD44 and ANG2 and all that leads them to go there and all. So your comment on this whole thing, Dr. Pooja?
So, sir, I would like to comment and especially correlate with the type of the management we usually try to give to the patient with these type of risk factors, specifically because, like say we as we discussed that the TNBC, they are the very higher risk group of the patients who are likely to have the brain metastasis and HER2 positive. So the likelihood of these positive receptors will really guide us that what sort of therapy, especially going for a surgical resection or going for radiation, whether whole brain SRS should be employed.
Correct. Yeah. Okay. Fair enough. So Dr. Tejpal, if you are there, we have breast cancer, we have lung cancer, we have brain secondaries. Fine. But then between that, in that group, tremendous, they are loaded and they are not well, and so they come with a lot of pressure. And then between that, how do we prognosticate? I'll give you a quick overview on that. TNBCs have the shortest survival. HER2 has got a little longer survival. And if you again look at very specifically TNBC, certain factors have stood out, like what is the performance status at which come. This has stood the univariate and multivariate analysis, and we have the number of MET, so on and so forth. And that, so now I'm presenting something called a disease-specific GPA and also. How do you prognosticate a diagnosed patient who has got brain secondaries, lung and breast, Dr. Tejpal? So I've given you the data, you can talk about it.
So traditionally, brain metastasis, the prognostic indices was the recursive partitioning analysis based on the RTOG trials. And their age, KPS, and status of extracranial disease was used to sort of classify them into three classes, where class 1 patients would do better and class 3 patients would do significantly worse. Over the last 10 years, that has changed. RPA classification is no longer used, and as you have shown in your slide, the initially the GPA, which was the graded prognostic index, came, and then the diagnosis specific GPA scores, and now even they are now modified, taking into account the molecular subtype of the cancers. I mean, briefly, they do take into account the age, KPS, extracranial burden, number of metastatic sites, but also the molecular biology of the disease, and thereby giving us a more refined and nuanced prognostication and able to differentiate between the prognostic groups much better than what we had with the RPA classification. So the good biology patients would do better, and the bad biology patients would not do as well.
Excellent. Thanks. A very good answer. Thanks so much. And I'm moving to Dr. Amit. Dr. Tejpal said that the whole prognosis itself is now looked through the prism of molecular profiling and all. So therefore, it's very given that first-line treatment decisions in lung or even in breast are now fully based on molecular profiling, so on and so forth. But then, would you think about brain and probable brain and established brain, or in future, that comes into play when you make your first-line decisions, Dr. Amit, if you are there? You're able to hear me, Dr. Amit?
Sir, Dr. Amit is not there, sir.
Okay. Dr. Govind Babu?
Yeah, Raja, I think you made an important point that, we've been clubbing all lung cancers together, all breast cancers together. You already made a point about triple negative being different. And even in triple negative, we today know that there are at least seven molecular subtypes. So all triple negatives are not the same. So I think that is where we are heading towards. And as you know, when we started treating lung cancer patients, we never used to look for CNS disease because we didn't have anything great to treat with. But today, it's become a part of the routine screening before we start, because we have therapies that can work on this. Just to give you an example, we know that ALK and EGFR mutant patients have a higher predilection for intracranial disease. And when we treat them with these targeted agents, their outcomes are also good. So we need to follow up them for the disease in the CNS and the responses as well. In fact, just to tell you, one of our patients who had intracranial mets ALK positive just last week has finished 7 years on an ALK inhibitor. So these responses and survival was never heard of before. So I think it is becoming important that we look at these specific things, and we are definitely going molecular way, as you mentioned.
So we are definitely, that's what Dr. Govind says, definitely going molecular way in even deciding on, even before we plan the first line. And the brain really looms in front of us, whether it is there or not, when we make some decision point. Totally agree. So I'll now come back to Dr. Venkatraman. There are excellent data. Osimertinib. We have the Bloom trial that has talked about the response even in leptomeningeal disease. And we have the in advanced disease setting, the FLARA, and the RA3 data set has clearly shown that there is a CNS response rate and the duration of response. And the PFS definitely is better when we do with all these things. Now, talking about lung specific and talking about osimertinib. My question to you, Dr. Venkat, is the topic today is that OAS and QOL. So are we really achieving OAS and QOL with targeted therapy? Let's not talk about ALK at this point. Govind has said that, we'll come to it. Among EGFR TKIs, is the data supporting OAS and QOL, Dr. Venkat?
Yes, sir. Among EGFR, definitely there is an OS benefit with osimertinib as well as dacomitinib. And OSI also shown benefit in patients who have CNS metastasis and also reduces the risk of CNS metastasis on patients on the drug. So yes, there is definite evidence that these the newer generation of TKIs are better than the older ones like geftinib and erlotinib.
So you definitely is there a QOL data set on this, on OS superiority data set there, Dr. Ashish? Would you agree with that?
Vaguely, there's some QOL benefit. I'm not sure.
Okay. Yes. Ashish, your comments on specific to the topic of discussion today, OS, QOL, is it fully established with even with early disease EGFR data? DFS is proven. PFS is proven. Your comment on OS and QOL.
Yes, sir. So I think times have changed. Now even these large registration trials are allowing patients with untreated brain metastasis. We have seen that with lorlatinib, we have seen that with alectinib, even osimertinib. And then obviously these trials are not powered for a small subset of patients' brain mets, but the duration and the durability and number of yes sir yes sir and it's obvious that like if we are getting such good disease control, CNS is a site, it will manifest in better quality of life, better neurological deficits and those things. So
totally agree.
Yes.
And Dr. Govind,
So Raja, we are talking about brain involvement. And it's no brainer that brain metastasis does affect quality of life to a large extent, unlike metastasis in other sites of the body. I think it will definitely make an impact.
It is no brainer. Just treat the brain, you will still have quality of life. That's what you want.
Yes, exactly. Because I think brain mets produces maximum amount of fall in quality of life.
So you have already finished the panel, Govind.
Oh my God.
See, now, most pleasure. See, this is now your patient related. Now, alectinib has got PFS benefit and time to progression, and brigatinib. Among the ALK inhibitors, these two have compelling data on CNS superiority. And you have already indirectly answered. I'm not even going to ask in ALK whether QOL data or OS is there or not. It is already sealed deal. Totally agreed. So now I will ask you one more question, Dr. Govind. What about immunotherapy agents? Do they give us that OS and QOL benefit if there is a brain mets? That's the question.
Yeah, actually, it is shown. I mean, we don't have separate data for brain mets with IO drugs, but the subset analysis has definitely shown that there is benefit. So I think if you're able to control the intracranial mets, definitely it is worthwhile.
But yeah, that's the, even though, I mean, I think you answered that. The only data set that I can throw here is that Caspian data, even though small cell lung cancer definitely has shown that there is an OAS benefit even in patients with that is solidly established.
Correct.
This is the, I mean, at least if we know exactly what we are treating, then probably that's going to help on our question. So now we'll come to breast cancer, whether we have solid evidence that in breast cancer also specific treatment will help us or not. I'm going to ask Dr. Tejpal that question. In breast cancer, HER2 driven disease, we have what we call this, data set out of HER2 climb, and in Destiny, they have shown again PFS and DOR and all that. And at least the HER2 climb, there is an OAS data benefit that is demonstrated. So do you believe that specific therapies in brain met in breast cancer, we are demonstrating OAS benefit and QOL benefit, Dr. Tejpal?
Yeah, so I think just like the lung cancer landscape, I think even in the breast cancer brain metastasis, these agents have made an impact and have definitely improved overall survival and as well as the quality of life. And as Dr. Govind and you pointed out, the maximal impact or the maximal detriment in quality of life is with progressive brain metastasis. So if you can actually control the brain disease and reduce the incidence of further brain progression, you would automatically improve the patient's, stabilize the patient's quality of life. So just like in lung, I think even in breast cancer, the landscape does show that these drugs are effective.
Okay, thank you.
5 minutes left, sir.
Yeah. How much time, Kashish?
So 5 minutes, sir.
5 minutes, So
you can take by 5 minutes also, because we are going to finish all the expert comments during the panel. So don't worry.
Yeah, thanks, Govind. So Dr. Pooja, will come to what you pointed out. Among the local therapies, surgery or stereotactic radiosurgery or whole brain RT, I was trying to look at this answer, whether in any of these things individually, lung, EGFRs and like that, and breast, individually, whether each one of them has shown OAS, QOL. That was the answer I was trying to dig out for this panel. Surprisingly, what I found is that surgery followed by whole brain RT has clearly shown OAS benefit documented and all. I was trying very hard to figure out that in other subset of loco-regional therapy. Even the TKIs, although all of us are very, very convinced, they don't have full mature data, but we have clinical feel. Dr. Pooja, your comment on loco-regional therapy and to the point of OAS and QOL being established with that.
So specifically, I would like to highlight 2 points in this regard. So it's very correctly mentioned by the panelists that our intention is that we try to decrease the progression of the brain metastasis and try to prolong the time to the neurocognitive progression and the neurological progression. But having said that, when you're talking about aggressive local therapies, I think it's very important to understand the disease burden, not just the systemic disease burden, but also the cranial burden, that whether it's just a single lesion or it's a solitary. I think we've been taught in our residency days that if it's a solitary lesion, use full of your resources, because that is the subset of the patients who are going to respond most likely and the maximal. So having said that, if it's a solitary lesion, probably I think surgical resection followed by a SRS boost would be the ideal way to achieve the best loco-regional control and try to have as maximum overall survival possible.
So Dr. Pooja, to you the same question here, that up till how many brain met today would you want surgery? I mean, is it 3? What I've shown here, the data set from Leon and Leon, or is 5 okay to operate? Do you have an idea on that, Dr. Pooja?
So, sir, I think it's first of all, more than the number, it's the comfort zone of the surgeon, first of all, to have it removed. That's the RZ resection possible. And sometimes, surgery is also been used first line just to have the decompression, immediate decompression of the symptoms, So I think that glitch would drive with the surgeon expertise.
Totally agreed. Thank you for that. Dr. Venkat, when would you ask your, when would you ask your surgeon to operate, Dr. Venkat, from Medonc point of view? when are you going to refer to the surgeon or to the radiation doctor? Do you have a any algorithm to take that, Dr. Venkat?
It depends on case to case. If somebody has very low disease burden, met, so then I would refer to the surgeon. Multiple metastasis, patient doesn't have a driver mutation, I would ask for radiation. If the patient is unable, if has a driver mutation but is unable to afford a which penetrates the CNS, for example, if I can only give Jeptinib to a patient, I know that CNS penetration is going to be poor. These patients I would refer to my radiation colleagues.
Okay, case to case basis, fair enough. Dr. Ashish, when would you refer for SRS? And I know we are all med-oncs, but then we need to have some idea. And when would you agree with your radiation doctor when they say that we want a WBRT, whole brain RT? Do you
yes, sir. So I think if I have a systemic therapy option which I can utilize, and I'm confident that patient is going to live many months to many years. The problem with whole brain RT is the cognitive decline, Parkinsonism, and those things which can functionally affect the patient. And also, so therefore, like for example, an EGFR mutated or an ALK mutated lung cancer, I would want to avoid whole brain RT as much as I can. Even now in HER2 positive with so many CNS acting agents. And we all assume that our systemic therapies isn't going to be great in the CNS, but now with the data we see, we are having excellent responses. So whole brain RT should be a fallback option and should not be a norm upfront.
Yeah, as much as possible, keep it away. That's what you are trying to say. Totally agreed. Dr. Tejpal, would you also agree on as much as possible keep whole brain RT away?
I don't agree on that. I think the case selection is very important. If a patient has a very poor performance status, a lot of leptomeningeal disease in the brain, uncontrolled systemic disease, I think palliative whole brain radiotherapy should be given. Of course, if the patient has excellent performance status, low disease burden in the brain, as well as low burden systemically, then radiosurgical treatment can be offered for the brain metastasis. I think in India, still whole brain radiation therapy has a role and place, particularly in patients who are not going to live very long.
So that's good. Thank you. You have a counter argument. You know, this is the Japanese radiation oncology data set, URTC, and based on this Astro, and also I will bring it to Dr. Pooja. When would you say SRS, and when would you be not comfortable with SRS alone and go for? Do you have a number or any way to approach that, Dr. Pooja? Apart from the systemic disease burden, just looking at the brain alone.
So sometimes even the tumor volume also helps us to decide whether we should be going for SRS. If it's a high volume, more than 30 cc, probably those are the patients where I would not be happy enough to go for SRS. I would like to go for whole brain RT. And of course, the other factors we have already discussed, the systemic burden, the intracranial metastasis, the performance status. So, yeah.
30 cc, would you arrive at on a single lesion dimension, or you put all this together? How do you arrive at that decision, Dr. Pooja? I mean,
so it's the whole volume what we are talking about, the combined metastasis, whatever we are. And if it's a high volume, probably at that time the benefit of having the minimum toxicity is not possible. So in those circumstances, and taking into account the background of the disease, if it's a TNBC, I am sure enough she's going to relapse at some other point. So those patients probably whole brain RT would be fair enough.
Okay, thank you. Dr. Govind, we have talked about targeted, we have talked about so many. Is there any systemic drug therapy that you think has made the cut for improving the OAS or QOL in metastasis, brain and lung, or at least in the breast? Would you want to say something on systemic therapy, Dr. Govind?
Yeah, Raja, one of the things is if you have a targetable pathway, those drugs have made an impact. Especially the newer antibody drug conjugates in the for example, HER2 low or relapsed HER2 positive disease. These antibody drug conjugates have really shown benefit because they do have intracranial activity. Other thing is the CDK4/6 inhibitors. In the people who have progressed probably on first line or heavy burden disease, because some of the CDK4/6 inhibitors also have a action like the immune checkpoint inhibitors. So, and they're able to cross the blood-brain barrier because these are small molecules. So these are the theoretical possibilities that are being used to try and help intracranial disease. The other point which you were talking about, the role of surgery, with due respects to the neurosurgeons, because many of these patients reach neurosurgeons first, and they just take out the disease before even assessing various other factors. Of course, it is not for all neurosurgeons. That's why I said with due respects to neurosurgeons. Some of them we know do that. So I think we need to educate them as well, because I'm sure there's such rapid progress in oncology. We ourselves find it difficult to keep pace. So I don't blame them for what they're doing. So I think we need to update their knowledge as well.
Fair enough. I have a last question, but I'm going to cut across and go to my friend and colleague, Dr. Rakesh Jalali. Since the question, the topic is loaded as not just treatment, the question was specifically on, are we really making the cut on OAS and the QOL? From that point of view, if we take the cost out of the discussion, one, if you put cost, everything is going to be confused. And if Proton has to be discussed, do we believe that it will really add to the QOL or maybe definitely probably QOL? Whether the OS has been demonstrated, Rakesh, what is your comment on that? It's a complicated area. People can look at it either way, but what is your expert advice?
I get it. Before I step in for Proton, I know we have little time, but I just wanted to also make a comment. We haven't discussed in the entire panel the emerging and very well-established role of hippocampal sparing whole brain radiotherapy.
Completely agree.
It's a fascinating in TMH in 2012, and many people can do it with photon machines very well.
Sure.
And there are some patients, mind you, when you do SRS, it mandates, every single clinical trial has mandated 3-monthly MRI. And that is a compliance and landscape issue too. So in patients with short DFI, with HER2 positive, tiny bit of leptomeningeal enhancement, so on and so forth, it's always better to err on the side of caution to give whole brain. But I always try to do as much hippocampal sparing whole brain, because it will give you the best of the worlds. You will give you complete clinical control, neurological control, as well as preserved cognition, and there are randomized trials to show it. As you rightly showed in your own slide, very nice slide, the only thing which has actually improved OS is the presence of whole brain radiotherapy. So we should not disregard whole brain completely by ASCO, like she always say, because of many other factors. So we have to have a pragmatic approach. As far as Proton is concerned, for SRS, relatively small lesion, actually there is absolutely no difference. You don't need always a gilded, sword to cut the stone, as we say. You can do very well with conventional radiation technology. But if the target volume is irregular, for example, there is a big thrust on post-surgical cavity radiosurgery where you have to go right up to the approach of the craniotomy. There, the volume becomes very irregular and fuzzy, especially the leptomeningeal metastasis. So there is a role of proton therapy, and also there is small role of hippocampal sparing. Also, there is some dosimetric data at a slightly better edge. Finally, there is emerging data that if you want to do surgery, you do pre-operative radiosurgery. And there's an RTOG NRG trial going on at the moment in a selected group of patients as a local therapy where you want to avoid the whole brain, because then you don't get into large volume of post-operative cavity when you have a tumor very small. So you do pre-operatively maybe on a Friday or Saturday, and you resect it out on Monday. And that trial will be fascinating to watch.
So with those wise words, excellent. Thank you for those excellent comments. At least one important takeaway point from what he said is that hippocampal sparing whole brain RT has become the standard of care as far as and that's a very important take home points. And with that, I will, hand it over. I think our time is also right on the money. I'll hand it over to thank you so much, all the panelists, and I thank the organizers for this great opportunity. Thank you so much.
Thank you so much, sir. Thank you to Rakesh, sir. Thank you to our chairpersons and session directors. We'll now move on to our next session. This session is sponsored by Lilly, and it gives me great pleasure to introduce our expert moderator, Dr. Ghanshyam Biswas, and our expert discussion board, Dr. Ashish Singh and Dr. Kaushal Patel. So over to Ghanshyam, sir, to start the session.
Thank you, Kashish, and thanks Lalit, my roommate at Tata Memorial Hospital, for inviting, and thanks Eli Lilly. So that is a disclosure. So next. So I have with me Dr. Ashish, a good colleague of mine from down south. Next, and Dr. Kaushal from down west. So next. So I have a case. So in mid of, I can say, the COVID pandemic, a 69-year female who had a comorbidities, hypertension controlled, no addiction, no positive family history. There was a history of hysterectomy done way back in 1994 for a benign condition. Next. So this patient was initially got admitted during COVID time with one of our pulmonology colleague for a suspected COVID. So she had come with X-rays and an HRCT thorax. We know that HRCT was a common phenomenon during the COVID time. The patient only had a breathlessness. So if you see that November 2020 HRCT, so it showed a moderate to massive pleural effusion with a lung collapse and almost a 15 millimeter enlarged node. So a pleural fluid which was done outside cytology, we know that many times outside of 5 ml, 10 ml, 20 ml is only sent. So on no malignant cells. So while this patient got admitted here with us, so the pulmonologist advised a CT scan thorax, this time a contrast enhanced, though this patient had a PS2, I can say, because this patient was on a NIV support. So you can see the CT thorax showed a good amount of effusion, and it also picked up the lung lesions on the other side, pleural deposits, and hepatic, skeletal, and left adrenal and lymph node metastasis. So, and the scan looked like that the patient has a lymphangitis carcinoma. Since we don't have an in-house PET CT scan, so we had to resort to a CT scan. So the ICD was done on 29th of March 2021, and then I came into picture. So Dr. Ashish, so how do you approach this patient now?
Sure, sir. So this patient has a suspected lung cancer, and you said the cytology was not able to confirm the diagnosis. I mean, I would like to see the images, and so the first step here would be to, even though it's very obviously it's a lung carcinoma, but we would want a tissue for a diagnosis. So now, depending on the location of this lesion, I will have to. And also, you said the patient was suspected to have COVID, and patient was on oxygen, right?
Right.
So I'm assuming the performance status is limited, and I hope that the patient will be able to tolerate a procedure like bronchoscopy, because sometimes even that can be a little tricky. And even for a CT guided biopsy, the patient has to lie down, sometimes prone, and that may be difficult. So
absolutely,
with all these things, so I will be discussing with my pulmonologist, and depending on the location, extent, and size, we will plan a true cut biopsy, whichever way is feasible.
Yeah, next slide. So the USG abdomen was also done, so multiple soles. So when I examined, so I could palpate multiple breast lesions. So actually this turned out to be, so I thought that I had a diagnosis with a CA breast with lung mets, but actually on USG, because the patient was not fit for doing a mammography, so it was calcified lesions. So we could pick up a node, which was a neck node, so loop supraclavicular, so again 10 millimeter node. So CT guided biopsy came as non-small cell lung cancer adenocarcinoma. So Dr. Kaushal, so what next? We have done a CE also, which was 344.
Yeah, so clinically, as well as the laboratory investigation shows that it's an advanced adenocarcinoma of the lung in a female patient, probably non-smoker. So in this particular aspect, I would like to send the biopsy specimen for the NGS for molecular markers. And meanwhile, while coming with the reports, I would like to start with the chemotherapy, pemetrexed as well as carboplatin, depends upon the patient performance status.
Actually, the patient performance status has improved once the ICD was put.
ICD was inserted. Right. So I definitely go with the pemetrexed and carboplatin, because we are not aware or we are not in any assumptions which molecular marker will come to be positive.
So Kaushal, do you have an in-house in NGS?
Therapy in this case.
Do you have NGS? No, in-house.
No, I do not have NGS in-house, but I will send the NGS to some other laboratory,
Absolutely,
which will do the reports within 14 days, max to max.
So Ashish, so you have an NGS in-house. So do you do you?
Yeah, so I would differ with Dr. Kaushal. I mean, even if I have NGS, the turnaround time of NGS is going to be at about not less than 3 weeks. And here the patient is actually, I don't think, can wait without any treatment. I also agree that if it's an emergency, I would begin with chemotherapy. But I like PCR for the whole reason that if I tell the pathologist I need the report quickly, I can get it in 4 days. So 1 or 2 days for extracting the DNA, and then the 4th day that they can run the PCR. And in India, whatever said and done, even though we can have multiple mutations, but the commonest is EGFR. So I would still,
that is a great point.
Yeah.
The next slide. So that brings us. So actually, so would you advocate on MRI for all patients, or particularly we know that for ALK positive we are doing it. Suppose this patient turns out to be EGFR. So Kaushal, so are you going to do a brain MRI for this patient, asymptomatic?
Not all patients who are asymptomatic for brain MRI. Generally, we do the PET-CT scan for lung malignancy, and in that particular subset, we just see some brain. No doubt, the PET-CT scan is not the right investigation for the brain, but it's roughly give the idea regarding the brain metastasis. So in routinely, if the patient is not symptomatic for brain mets, then I will not go for the MRI brain.
But if you see the NCCN 2021, even 22 also, so besides ALK, even in the EGFR mutated patients, you need to do a CCT brain in spite of doing a PET-CT and preferably a MRI. So next.
Right.
So as Ashish rightly said, so I sent because from tier 2 cities, so it will take for me 3 weeks. So I sent the liquid EGFR, and you can see. So after on the 5th day, I had the report of EGFR L858R. So but subsequently, we had sent that NGS 5 gene panels supported by the pharma companies. So again, that also comes from EGFR exon 21 positive with a PDL1 of 50% and ALK, ROS, BRAF, and MET negative. So Ashish, so now how do you plan now? So this patient has received first cycle of zoledronic and a modified dose of PEM carbo. So I have given a 20% dose reduction because the patient was still in a semi-ICU. So how do you go about?
Sure. So this patient has high volume disease. This patient has a sensitive EGFR mutation. So in the first line options, if you ask me, currently in India, we have one is you've already started on chemotherapy. There is an option of adding gefitinib to chemotherapy. We all know the data from Tata Memorial, which has showed an improved in overall survival. Osimertinib is always an option, but the cost is an issue. And then doing only a first or second generation TKI, that like erlotinib or afatinib is also an option. But having said that, this being a L858R, the PFS expected is not going to be as great as what we expect in an exon 19 deletion. So therefore, my personal take would be to do something a bit more than just a first generation TKI. So for most of my patients who cannot afford osimertinib, I would be adding chemotherapy, or now, as we're going to discuss today, an anti-VEGF agent, Cyramza, is also a good option.
Right. So Dr. Kaushal, so as Dr. Ashish says, so this 70-year lady with the present general condition, so would you ever think of gefitinib? So if the patient is not affording for any osimertinib or relay.
Gefitinib plus chemotherapy combination in this patient. My choice of the treatments would be either it is osimertinib, acomatinib, or the combinations.
Kashish, there is a lot of background noise. Kashish. Kashish, lots of background noise. Yeah, Kaushal. So I'm asking,
Yeah.
so M-carbo and gefitinib, will you be able to give a 69-year patient?
No, I personally would not like to go for this combination in era of availability of the very good TKI or TKI plus VEGF combination without any significant toxicity.
No, Kaushal,
So I'm personally not interested in this combination.
If the patient is non-affording, so the patient may not afford for an osimertinib, the patient may not afford. So do you find a scope for chemo and first generation, like the TMH protocol?
In that case, we can think over the this combination, gefitinib plus chemotherapy combinations with certain modification of the dosage, we can say.
Yeah, because that is not a toxic regimen. So young patient, yeah. So definitely somebody who cannot afford it with end organ functions, so they can be a candidate. Otherwise, elderly patients with a good volume of disease, so I think so that patient will be difficult to handle. So next slide. So are all EGFR mutations equal? Next slide. So we know that exon 19 deletion and exon 21 substitution, that is L858R, the commonest. Uncommon is an exon 18 and exon 20. Now we have two drugs in hand. Next. So we'll resort our discussion to exon 19 and exon 21, L858R substitution. Next. Next. So Ashish, so the deletion 19, L858R. So are they clinically or biologically equivalent?
Yes, so I think initially, just if you would have asked me this question 10 years ago, I would have said they both are equally good. But now, even in our practice, we have realized that most patients who progress early are actually having L858R and not exon 19 deletion. And even in the trials of afatinib, we saw better results with exon 19, but not with L858R. And recently, if you see all the other large phase 3 registrational trials, this is a particular subgroup which is a sensitive mutation, no doubt about it, but not to the tune of what we would expect. And the PFS is really lower if you look at and compare. Yes.
So Kaushal, so do you find a genetic or a molecular difference or a clinical difference between a deletion 19 and L858R?
Yeah, definitely we have a difference between deletion 19 and L858R mutations. Clinically, I am very confident that the exon 21 is not so good compared to the exon 19. So it's a more aggressive disease, less responsive to the available TKI also, and the progression and metastatic rates are very high.
So any molecular heterogeneity you'll find. So L858R versus deletion 19.
Sorry, I am not aware about this thing.
So clinically you will see L858R like, and so usually they have a high volume of disease.
Right.
Second, so they have lots of effusion. So you'll see, so these are probably VEGF activity driven. So that is quite seen. So if I am asked to see a molecular differences, so we can go into the subsequent. We'll see that L858R has lots of co-mutations as compared to deletion 19. So so we are doing a broad-based NGS. So we have moved from 5 gene panel to 12 gene panel. So many of my colleagues are doing a Ross Foundation. So we are going to pick up additional mutations. So one of the importance is our TP53. So Ashish, so after the relay, now 1.5 years of approval in the country now. So do you think so EGFR mutated NSCLC are heterogeneous group and it's a time for a tailor-made approach?
Yes, sir. So as you said, we all have noticed that these patients have lower PFS, and then we must get into the reason for it. I mean, what is the reason for it? Is it that the mutation site per se, the drug doesn't bind very well? Or as you said, that it's a co-mutation. It's like for example, if you have a TP53, which is very common in lung cancer, and whether it's a TP53 being present in more number of patients with exon 21, and that is what is leading to a poorer prognosis.
So, so to answer your question in short, I think still, I mean, we only have a few limited studies to answer this, and I'm sure moving forward, we may kind of decide based on different co-mutations.
Yeah, so the future looks like, so there is something on the horizon. Next slide. So the EGFR mutation epidemiology, so we are aware of this. Next. So now if you look at the indirect meta-analysis, 6 studies, more than almost 1,400 patients. So first and second generations versus chemotherapy, overall hazard ratio of 0.59. So these are first generation and second generation. So next. So see those significant reduction of risk of progression or death, so was favoring exon 19 as compared to L858R. So these were indirect. Next. If you come to a direct meta-analysis of 7 studies, around 550 patients, so that also showed that probably exon 19 deletions, they are faring better than the L858R if you compare first and second generation with chemotherapy. Next. So as we discussed, so there is a sensitivity difference between L858R and exon deletion 19. If you see, so with a standard dose of one of the anti-EGFR, that is axitinib, so with a standard dose in a 19 deletion, so you can see a huge response, which is not seen with an L858R. But once you increase the dose of axitinib, so you can see an ORR or the median progression-free survival improved. So on a higher dose, so there is a sensitivity difference between both these EGFR mutations. Next. So higher incidence of concomitant mutations where Dr. Ashish also alluded. So you can see 40 versus 70%. So 30% difference, p-value of 0.04. So it is significant. So the population studied, again, a Chinese Wuhan. So you can say, so 58 cases. So they have done a panel of 49 genes. You can see, so 40% of concomitant or co-mutations in an exon 19 versus exon 21, 70%. So you can see the survival here. So that is a difference. So another TMB was higher in the L858R tumors as compared to deletion 19. Next. So we have choices of first generation, we have choices of second generation, third generation, and combinations of like the relay and the combination of gefitinib. So we have already discussed. So there is no place for erlotinib or gefitinib unless the patient performance is too bad, patient cannot afford. So you just give one of the oral pill and the patient goes back home. Otherwise, so we are looking at a third generation osimertinib or in the combination. So next. So I started by patient on ramucirumab and erlotinib. So if you see the survival, the PFS on the upper part, you can see these are all exon 19 driven. So first one, Flora, third generation, then Lux Lung, second generation, then Archer again, second generation. So you can see exon 19. So you can see a survival difference as compared to the lower part of the slide. You can see these are all exon 21. So probably the exon 21, the mean with the maximum PFS you could attain in a Flora was 14.4 months. And rest, so with afatinib 10.8, with erlotinib 8.4, and even in Archer 12.3. So probably, so from the relay, so this probably the genes was broken. So 14.4 month was next. So the patient continued with the Cyramza 10 mg per kg and erlotinib 150. So 6 doses, 3 cycles, a good partial response. Next. So this patient continued and I continued the same therapy. So the patient neither had a bleeding episode, neither hypertensive, only a grade 1, grade 2 rashes because of erlotinib. Next. So post 7 cycles, because you know that Cyramza has a good PAP, initial 2, so you'll have 1+2 and subsequently from third onwards, you'll have 1+3. So these patients, you can see the patient had a complete response, metabolic complete response. So Kaushal, in lung cancer, so be it immunotherapy, be it an anti-EGFR, maybe an osimertinib, chemotherapy. So how common is a CR? So any figures?
Particularly in EGFR positive patient?
Yeah, for EGFR positive patient.
Yeah, so we are nowadays we are seeing with availability of the good drugs like osimertinib, dacomartinib, and combinations of the VEGF plus erlotinib. We are frequently seeing the CR in our patients, and in my clinical practice, approximately 30% of the EGFR positive patients, they are getting CR with the TKI, third generation or second generation TKI or VEGF plus TKI combination.
So Ashish, do you agree with Kaushal? 30% CR.
Yeah, I don't do PET so often, so for me it's difficult to say some like metabolic CR, but I mean a good response is very common, and especially when you've added ramucirumab, so that increases response rates as well as duration of control. So that's what we are seeing here.
Yeah. So Kaushal, if you see,
And
see the trials also.
Maybe I'm just thinking maybe I should start doing PET, because now we are seeing evolving data of if you don't have a very good response in the primary, one can even consider a little bit of local radiation and things like that.
So oligoprogression, right?
Yeah, or if there's only a residual tumor at one site.
Right. So Kaushal, so if I quote the literature, so Flora, so with osimertinib, so it was only a 3% CR. But if you see a relay, so it was only 1%. So I think 30%. So maybe on a CT scan, so you can do it, but probably PET CT scan, so probably it won't be a 30%, because 30% in an advanced lung cancer is quite a lot. Next slide. So now the patient has completed 19 doses on 17th of February. So absolutely doing fine. So continues to be a CR. So the next evaluation is in April. Next. So this one we have already discussed. So there is an importance of concomitant mutation. So as far as broad possible, so at this moment we know there are companies who are supporting for a 12 gene panel. So at least all of us should resort to a 12 gene panel. So maybe after a year we'll have 1,000, 2,000 patients. We can also find out some concomitant mutations, and probably we can select our patients. Next. So as Dr. Ashish already said, the presence of TP53, which is very common in a lung cancer, and other coexisting in the EGFR space, were associated with the inferior OS, including patients who had an emergent T790. So you'll think that the T790, so this patient is going to benefit the osimertinib, but if this patient also harbors a TP53, so you'll see the patient has progressed within few months. So you may not have a desired response. And another important thing is that an increase in TP53 mutation allelic fraction may potentially be a useful clinical predictor of a small cell transformation. Next. So in relay, the prevalence of TP53 was almost the same in both the groups, but at progression it was 17 versus 15%. So probably this anti-VEGF has done something to downregulate. So in patients with TP53 mutations, this combination had a superior PFS as compared to the placebo plus erlotinib. So the wide range of pre-existing co-occurring and treatment emergent genetic alterations is an important. Next. So any role of immunotherapy during the course of treatment, because this patient had a 50% PD-L1. So caution.
Yeah, if the patient progress over this TKI plus VEGF combinations, even after using the osimertinib, and still the patient is progressing, then we can have some definitely role of the IO in view of the PD-L1 is 50%.
So which line?
So we are very
line. So which line? Second line or third line?
Third line.
Okay. Right. Next. So the lack of efficacy with immune checkpoint inhibitors we already discussed. So probably, because with relay, you'll still get a 40 to 45% of the patient on progression has a T790M, so which will be a candidate for osimertinib. So probably down the lane, then these patients become a candidate for immunotherapy. Otherwise, these patients probably, those who doesn't have a T790, probably they are candidates, or at least not in the upfront. Next. So if you see the potential toxicity, so there is an important paper which showed that use of immunotherapy followed by osimertinib. So any correlation, Ashish?
Yes, so I would like to differ a little bit here. I think the only data we have with immunotherapy in this disease is a post-hoc unplanned subgroup analysis of the ABCP trial. And it is intriguing, but then we still have to learn which patients do respond. It's very small numbers, just some 20, 24 odd numbers.
Right.
And single agent activity of, even if most of them, in spite of having high PD-L1 expression, their tumor mutation burdens are low and they do not benefit with IO. And also, if you bring in IO a little early, and then you have to go back to a TKI after IO, that has been associated with a severe pneumonitis. And I think that is what you were trying to show on this slide.
Absolutely.
That patients who have received IO. So many times there are case reports where before EGFR report came, the patient got chemoimmunotherapy, and then once you started TKI, there was very bad pneumonitis. Because these immunotherapy agents have a very long half-life and they stay in your body for many months, even after the last dose. And that is not safe.
Next slide. So is it a myth? So we have seen a 19.4 months. So from the relay, and 19.6 months was for the exon 19. So which was never achieved before, even with the flora. So next. So that brings to the last slide. So thanks Dr. Ashish and Dr. Kaushal. Thanks Eli Lilly, and thanks Icon.
Thank you so much, Kancham sir. Thank you so much, Ashish sir. Thank you so much, Kaushal sir. We would like to announce that this session is sponsored by Lilly, and a big thank you to them. We'll now move on to our next session. Sophia, can I request you to please share your slide? So this session is sponsored by Roche, and the topic is the role of Alecensa in 1L ALK positive NSCLC patients beyond the barriers. And our speaker is Dr. Lalit Sharma, consultant medical oncologist, Manipal Hospital, Jaipur. Over to you, sir.
Yeah, good evening, everyone. And can I share the slides from my end?
Yes, sir, please go ahead, sir.
So at the outset, I would like to thank the organizers for giving me this opportunity. And so my talk would be covering the role of axitinib in the first-line setting in ALK positive non-small cell lung carcinoma. So as far as non-small cell lung carcinoma is considered, it is the second most commonly diagnosed cancer worldwide and the leading cause of cancer-related deaths. The adenocarcinoma is the most common form of the non-small cell lung carcinoma, attributing almost half of the cases in the non-small cell carcinoma subset. And even the scenario is same in the Indian population also, with a large number of cases being identified every year with significant burden of mortality also. So as far as the approach towards diagnosing these cases is more and more stress is being put on identifying the individual molecular pathology which is driving these cancers. And if we have a look at these, the most common driver mutation in non-small cell carcinoma is considered to be EGFR, and ALK is found to be representing anywhere between 3 to 9% in various ethnicities and various populations. Even in the Indian population, various studies have put the figure anywhere between 3 to 7%. The way to arrive at the diagnosis of ALK positivity or negativity are either FISH or IHC, RT-PCR, or next generation sequencing. More and more of patients are being diagnosed via the wide gene molecular marker tests via the NGS more and more frequently. And the ALK positive disease can be considered to be a distinct subset of non-small cell carcinoma, as it is more common in the non-squamous histology more common in patients who have either never smoked or are former smokers, more common in the female gender, in the younger populations, and patients who do not have EGFR or KRAS mutations. And these clinical characteristics do not always predict the presence of ALK positivity. So it is rather suggested that all patients, especially non-small cell lung carcinomas, should be subjected to wider molecular profiling. So as far as ALK positive non-small cell carcinoma is considered, the ALK mutation leads to a rearrangement, leads to structural alteration in the chromosome and increased expression of the ALK fusion protein. And this leads to tumorigenesis and proliferation of the cells in an uncontrolled manner. The overall incidence is kind of the tumors of 3 to 7% in the various registries which we have in India. And the approved agents for ALK inhibitors have been either the first-line ALK inhibitors such as crizotinib, then there were second-line ALK inhibitors, ceritinib, alectinib, and brigatinib, and now we have the third-generation drug lorlatinib approved for this particular setting. So we would like to examine these drugs individually to come to a conclusion how these drugs individually fare in this particular setting. Crizotinib is a small molecule inhibitor, and it inhibits the activation by blocking the ATP binding site and downstream regulation, and hence stopping the oncogenesis. Now, Profile 1014 was the randomized multicenter phase 3 study, which kind of examined the role of crizotinib in the first-line ALK positive setting. The ALK positive disease was kind of detected with the help of FISH. Locally advanced and metastatic patients were considered in this particular trial, and they should not have been received any kind of platinum-based chemotherapy with an ECOG performance score of 0 to 2. Patients were divided into two arms. The observer arm receiving crizotinib 250 mg twice a day, and the comparator arm had pemetrexed and cisplatin or carboplatin, and the patients were followed till progression. Crossover was permitted at the time of progression. The primary endpoint was PFS, with secondary endpoints of overall survival and overall response rate and safety profiling. So in Profile 1014, crizotinib fared really well as compared to chemotherapy, with a progression-free survival of 10.9 months versus 7 months with chemotherapy, with an incidence rate hazard ratio of 0.45. So more importantly, the crizotinib had a better response rate of the tumors of 74%. The time to response was also lesser as compared to chemotherapy, and median duration of response were also almost double. So this probably told us that probably a targeted approach towards these patients would be far better as compared to chemotherapy in the first line setting. The median follow-up at 46 months showed that a 4-year overall survival was 56% versus chemotherapy faring at 49%. As far as safety profile was considered, vision disorders were more common with crizotinib, and so was transaminitis in this particular trial. So crizotinib, the issue with crizotinib, which we later on came to know, was that it enters the brain by crossing the blood-brain barrier and there is a drug efflux transporter, that is protein P-glycoprotein, and it is expressed in several tissues and is being freely expressed in the brain also, and hence it is exported back across the blood-brain barrier into the bloodstream and in an ATP dependent manner. Now, crizotinib is exported back across the blood-brain barrier, and this leads to a low brain-to-plasma ratio, and probably that is the reason why its activity in the CNS tissue was not found to be that good. So the active transport of crizotinib out of the brain results in the low brain to plasma ratio of the crizotinib, and therefore explains the CNS being a frequent site of recurrence on patients who are on crizotinib. Now, the proposed mechanisms of resistance to crizotinib or to more or less any kind of targeted therapy or a TKI is either there are an additional mutations developing, or there is a gene amplification, or add-on mutations might occur in these individuals. So similar was the scene with crizotinib. Either there were other oncogenic driver mutations such as EGFR mutation, which was found to be most common, and then either secondary mutations might occur which might increase the ALK affinity for ATP and therefore reducing the crizotinib binding. Copy gain number was another mechanism which was found. So the second line or second generation ALK inhibitor which was studied in ASCENT-4 was ceritinib, and this was a phase 3 trial in the first line setting, wherein patients with locally advanced or metastatic patients with an ALK positive tumor identified via IHC and with no prior treatment except patients receiving treatment either in the neoadjuvant or adjuvant form were considered. And these patients were divided into the comparator arm having pemetrexed or and cisplatin or carboplatin based chemotherapy versus the ALK inhibitor, that is ceritinib, at a dose of 750 milligram per day. The primary endpoint was considered to be the PFS. Ceritinib fared well with a PFS of 16.6 months versus 8.1 months in the chemotherapy arm. And moreover, in the subgroup analysis, ceritinib did not fare that well in patients who had brain mets at baseline. Again, probably the reason being that the CNS levels were not that well as compared to the serum levels. And moreover, in the ceritinib arm, there were more dose adjustments required, and the toxicity was similar for ceritinib and chemotherapy. However, percentages of those adjustments were higher for ceritinib, especially due to GI toxicities and transaminitis. So both crizotinib and ceritinib are exported back into the serum by the substrate, they being substrate for P-glycoprotein, and the CNS exposure in both these diseases is inadequate to control the disease, and the CNS becomes a sanctuary site for tumor growth in patients who are receiving these two drugs. And moreover, more or less an equal percentage of patients on these patients had, almost half of them had a CNS as first site of progression. And this CNS progression may occur due to development of one or more of the known mechanisms of resistance to ALK, or alternatively, the CNS progression may be due to the insufficient penetration of the ALK inhibitors. So then to examine alectinib in this particular setting, alectinib, as we could see here, is a pan TKI, has an activity towards almost a pan TKI setting, and the potency is kind of very well depicted here. Alectinib is also a potent inhibitor of some mutated versions of EML4 and ALK fusion protein, and some of which are resistant to crizotinib also. And here we could see that in the preclinical models, the investigators found that the levels of alectinib were far better, and probably it was because alectinib is not a substrate for P-glycoprotein, and hence the higher brain to plasma ratios. So Alectinib, so here is considered to be different as compared to the serotinib and crizotinib in the form of its better selectivity, higher potency, and its activity towards the resistant mutations and a better CNS penetration. So, moreover, in the first line setting, there is a large body of evidence which is available for us to examine, and the results in almost all these phase 3 trials have been consistent, supporting alectinib as the preferred first line treatment option. Now, Alex was the one of the large studies which examined alectinib in the first line setting in patients with locally advanced and metastatic non-small cell lung carcinoma. ALK positivity was ascertained by IHC, and the patients needed to be treatment naive. Patients in the experimental arm received alectinib 600 milligram twice a day versus the comparator arm receiving crizotinib 250 milligram BD, which was standard of treatment at that point in time. And patients were followed till progressive disease, toxicity, or withdrawal, or due to or death. The primary endpoint was PFS. Patients were stratified well for CNS metastasis, their ethnicity, and performance score also. Secondary endpoints were considered to be overall response rate, duration of response, and overall survival. So Alex was one of the comprehensive studies wherein not only the primary analysis was done, but then there was subsequent exploratory analysis also. And the patients were followed with tumor imaging at baseline, and subsequently every 8 weeks brain imaging were done to look for evolution in the CNS disease in this particular trial. And alectinib fared really well in the sense that there was a 34.8 versus 10.9 months progression-free survival, which was almost 3 times of the comparator arm, and a nearly 3-year freedom from progression was achieved. Even the PFS event-free rate was quite impressive, with almost 43.7% of patients at 4 years were event-free. So during the exploratory analysis, the data was kind of consistent with the primary analysis, and the hazard ratio for investigator-assessed PFS was below 1 for all subgroups by baseline risk characters. So the magnitude of the PFS treatment effect was consistent across the majority of the subgroups, indicating a better response. Now, as far as the response for patients when stratified for baseline CNS mets, it was kind of consistent, and in patients with CNS mets, the PFS was around 25.4 months, whereas in the patients without CNS mets, the PFS was around 38.6 months. Hence, the protection that lasts years was seen irrespective of the CNS metastasis at the presentation. Even the PFS event-free rate was kind of similar in both the CNS mets at baseline versus without CNS mets, though it was not that impressive in patients with CNS mets at baseline. So the cumulative incidence of the CNS progression was reduced to the tunes of 84% as compared to crizotinib. Both alectinib and crizotinib achieved a higher overall response rate, but more significantly, the duration of response was longer with alectinib, and this suggests this probably led to better translation with the significant PFS benefit observed with the alectinib versus crizotinib. So duration of response was far better with alectinib as compared to crizotinib. Hence, treatment with alectinib significantly reduced the risk of CNS progression in patients without prior systemic progression. And if we see here, a cause-specific hazard ratio of a very impressive 0.16 could be seen in such a setting. Now, in patients who were in the alectinib arm, around 3 patients got CR, and whereas none got a CR in the crizotinib arm. So in the intention to treat population, around 43% patients demonstrated a deeper response, in the sense that more than 75% tumor reduction was seen in around 40% of the patients, as compared to only a quarter receiving a more than 75% tumor reduction in the crizotinib arm. The overall survival data is still not mature, and the investigators are kind of waiting for at least 50% of the events to occur. And though a 5-year overall survival rate is of around 60% with alectinib at an updated analysis versus versus 45% with crizotinib. As far as safety profile is considered, as the patients have almost 3 times median treatment duration, so it could be considered to be manageable treatment side effect profile, and the drug could be considered to be a well-tolerated one. And when it comes to Asian versus non-Asian population, the response was probably kind of equal in both the populations, with the hazard ratio being consistent in both the populations. And even in patients who had CNS progression was significantly lower with alectinib versus crizotinib in both the Asian and the non-Asian population. So what
2 minutes
the
left,
event profile. Now the other option which we have is sequencing of the drugs in such a setting, but treating with first-line alectinib provides with the longest duration of the disease control, along with the defined treatment sequence, increasing the prognosis for patients with advanced ALK-positive non-small cell carcinoma. So to conclude, alectinib is the preferred first-line treatment option for ALK-positive non-small cell carcinoma because it has demonstrated the longest median PFS of any ALK TKI, almost of the tunes of 3 years in the first-line setting. It effectively protects against and treats CNS metastasis, and it is the only ALK TKI to have demonstrated a clinically meaningful benefit in the overall survival, with around 62% alive at 5-year assessment. It is well tolerated and has a well characterized and manageable safety profile that is maintained with long-term use. Thank you for your patient hearing.
Thank you so much, sir. We'll move on to our next session. This session is sponsored by Pfizer, and our speaker is Dr. Deepak Gupta, Senior Consultant, Department of Medical Oncology at Bhagwan Mahavir Cancer Hospital, Jaipur. Over to you, sir.
I'm not able to share my slides.
So you can share your slides now.
Okay. So very good evening, and thank you, the organizers, for providing this opportunity to present data on lorlatinib as a first-line option for ALK-positive metastatic NSCLCs. So this is the lung cancer incidence. You can see the time trend predicted, incidence increasing, and then mortality also from 2020 to 2040. So ALK rearranged adenocarcinoma accounts for 1.6 to 11.7% in different registries. This is the data which is from the Indian data, which shows ALK to be of 7%, but it is definitely variable across various populations. So clinicopathological characteristics of ALK positive lung cancer, it is associated with minimal or no smoking, adenocarcinoma, younger age, and lack of concurrent driver mutations. And approximately 30% have brain metastases, 3 to 5% unselected population of NSCLCs have ALK mutation. So ALK inhibitor development timelines. So it was discovered in 2007. Then crizotinib was first drug to be approved, and subsequently second generation inhibitors like ceritinib, alectinib, and brigatinib were approved in 2017. In 2019, lorlatinib came into picture for relapse cases, and then in 2021 it was approved for first line. So as I've already told, 3 to 5% of all advanced NSCLCs are ALK rearranged, and this is the first generation. Then second generation are ceritinib, alectinib, and brigatinib, and third generation is lorlatinib. So you can see that there is increasing potency from first to third generation, increasing activity against various ALK mutations, and increasing CNS activity also from first to third generation ALK inhibitors. So this was the profile trial based upon which the crizotinib was first approved in second line and beyond with median PFS of 7.7 months. And in profile 1014 trial, it was approved in first line with a median PFS of 10.9 months and hazard ratio of 0.45. When we compare the first and second generation data, although there is no head-to-head trial available, so you can, this is the PFS curves for various first and second generation. So with crizotinib, the first line PFS is 10.9 months. With ASCENT-4, it is 16.6 months. With alectinib, it is 34 months. And with ELTA1, brigatinib, it is 24 months as compared to crizotinib as a comparator arm. So lorlatinib was rationally designed to address the unmet need in ALK positive NSCLC. So what are these unmet need? This is metastatic brain disease, and second is acquired resistance to ALK TKI. So lorlatinib has advantage over crizotinib that it has effective CNS penetration and retention, and it binds with high affinity to most ALK resistance mutation also. So when we sequence the ALK inhibitor from first generation to second or second to third generation, so sequential 3 generation of ALK TKI leads to more incidence of double mutations like G212OR or L1196M, or even various other monster mutations which are resistant to many ALK inhibitors. So rationale for upfront use of pan-inhibitory agent. So lorlatinib suppresses the emergence of single ALK resistance mutations, and upfront lorlatinib could significantly delay or suppress on-target resistance also. So CROWN was the study which is the main topic of the presentation. So key eligibility were stage 3B and 4 ALK positive NSCLCs with no prior systemic treatment for metastatic disease, ECOG performance 2 up to 2, asymptomatic or untreated CNS metastases were permitted, and one or more extracranial measurable target lesion was allowed with no prior radiation required. They were randomized to lorlatinib 100 mg per day versus crizotinib 250 mg twice a day, and they were stratified by presence of brain metastasis or ethnicity, Asian versus non-Asian. Primary endpoint was PFS, secondary endpoint PFS by investigator, oral response rates, intracranial overall response rates, overall survival, safety, quality of life. So 296 patients were randomized and 149 to lorlatinib and 147 to crizotinib. 5 patients in crizotinib arm did not receive treatment. All patients underwent restaging, CT scans and brain imaging every 8 weeks. 103 patients in lorlatinib group and 31 patients in crizotinib group remained on study treatment. Median duration of follow-up for PFS was 18.3 months and 14.8 months respectively. So these are the baseline characteristics, more or less well balanced. Brain metastases at baseline were present in 26% and 27% of patient population respectively in lorlatinib and crizotinib arm. Asians were 44% in both arms. So primary endpoint was PFS by central review. So 12-month PFS rate was 78% as compared to 39% by crizotinib, with a median PFS not estimable versus 9.3 months with crizotinib, and hazard ratio of 0.28, which is the lowest PFS ratio rate seen with any drug in ELK setting. PFS by investigator assessment was 80% versus 35%. Again, hazard ratio was 0.21. When we see the subgroup analysis, almost all subgroups were benefited by lorlatinib, like brain metastasis present or absent, ethnicity, although it favors more non-Asian, but both groups were benefited with lorlatinib as compared to crizotinib. Then performance status, gender, age, smoking status, never or current or former status, they were all benefited with lorlatinib. Oral response rates by central review. So CR rate was 3% with lorlatinib as compared to 0 by crizotinib. Partial remission in 73% and 58% respectively. Median duration of response was not estimable versus 11 months, and median time to response was 1.8 months in both arms. Intracranial overall response rates by central review. So in lorlatinib arm, intracranial responders were 82% as compared to only 23% in crizotinib arm. With intracranial complete remission rate was 71% versus 8%. Median duration of response was not estimable versus 10.2 months. Intracranial time to progression, that was also significantly better with lorlatinib. Those who had CNS event were only 3 as compared to 31 in crizotinib arm. Median time to CNS progression was not estimable versus 16.6 months, and the hazard ratio was 0.07, which is the lowest hazard ratio seen for intracranial responses. Oral survival is not mature, so median OS was not estimable in both arms, but projected hazard ratio is 0.72. Safety summary, lorlatinib has definitely had higher toxicities. So grade 3 and grade 4 toxicities were 72% versus 56%, with serious adverse event 34% versus 27%. Fatal adverse event were 5% in both arms. Adverse event leading to permanent discontinuation were 7 and 9%, and leading to temporary dose reduction was 49% and 47%. So these are the toxicity profile. So more toxicity seen with lorlatinib was altered lipid profile in form of hypercholesterolemia, hypertriglyceridemia, peripheral edema, weight gain, and cognitive effects, psychiatric disturbances, but diarrhea, nausea, vomiting, and altered liver enzyme were more commonly seen with crizotinib as compared to lorlatinib. Global quality of life scores, changes from baseline was better with lorlatinib as compared to crizotinib. So if we compare all first-line ELK TKI studies available, so if you see the median PFS, so median PFS is hazard ratio is 0.5 with alectinib, brigatinib also 0.49, and with ensartinib also 0.51. But it is very low with lorlatinib 0.28, which is not seen with any study till now. And CNS CR rate is 71%, which is also highest till date with any study in ELK positive NSCLCs. So alectinib, brigatinib, and lorlatinib, these are all recommended as category 1 for first line setting in ELK rearranged NSCLCs. And so why this slide shows that why we should use the most effective drug in upfront setting, because in TKI treated ELK NSCLCs, decreased patient N is 74, and ongoing therapy in 70 patients. So these 74 patients, they died even before getting the second line treatment. So if, in this pie chart, you can see that majority of patients, they had rapid decline and death before the ineffective treatment could be switched, means they could not be started on second line effective treatment when they are using sequential treatment with first line and or second line followed by more effective later line of treatment. So it is always better to start with highest effective treatment, and patients should get benefited with that. To conclude, lorlatinib resulted in significantly longer PFS, significantly higher overall and intracranial response rates, and improved global quality of life compared to crizotinib in first-line treatment-naive ALK-positive NSCLCs. Intracranial response rates 82% and complete response rates of 71%, with significantly longer time to intracranial progression. Safety profile of lorlatinib was similar to that reported in previous studies. Grade 3 or 4 adverse events were more frequent with lorlatinib than crizotinib. However, majority of were laboratory abnormalities that were asymptomatic and they were readily managed with drugs. These results support the use of lorlatinib as an effective first-line therapy for patients with advanced ALK-positive NSCLCs. Thank you.
Thank you so much, sir. We'll now move on to our next session. This session is on lung cancer, and it gives me great pleasure to introduce our two chairpersons, Dr. G.S. Bhati, who's a senior professor, Department of Medical Oncology at Dr. Sapurna Anand Medical College, Jodhpur. And our second chairperson is Dr. Anushri Punya, associate professor, Department of Radiation Oncology at Shri Ram Cancer and Super Speciality Center, Mahatma Gandhi Medical College and Hospital, Jaipur. Over to our chairpersons for the introduction and the welcome note.
Thank you, Dr. Malhotra and Dr. Lalit, for inviting me. ICON. Time flies. In 1999, in Jodhpur, the ICON was started, and the 10th ICON meeting was in Jodhpur. Still, I remember, and now this is 46. Now,
we also remember Bhati sir. We also remember that Manuar Resort, and we will request you to host one more meeting of ICON, sir, before we retire.
Sure, most welcome. Most welcome.
Thank you so much, sir.
Now, without wasting my time, I will invite one of the best speaker in the country, that is Dr. S. Prabhasankar, and he will speak on targeted BRAF activation as the acquired resistance to EGFR mutated non-small cell lung cancer metastatic. Dr. Prabhasankar.
Thank you, sir. Thank you very much for those kind words. I'll just share my screen and we'll get started right away, sir. I hope my slides are visible and I'm audible.
Yes, yes.
So a very good evening and a warm welcome to everyone. At the outset, I'd like to congratulate the organizers for putting together this wonderful academic feast and also thank them for the opportunity. So over the next 10 to 12 minutes, I'm going to take you through the molecular aspects of targeting BRAF activation when it happens as an acquired resistant in patients with stage 4 EGFR mutant non-small cell lung carcinoma. So we know that we have come a long way, not just from the 10th ICON to the 46th ICON, but also in terms of the molecular heterogeneity in non-small cell lung carcinomas. We have come from just the histological classification of squamous and non-squamous to where we're talking about at least 10 to 12 targetable driver mutations as far as EGFR, ALK, ROS, BRAF, MET, HER2, NTRK, and so on and so forth. So that's how far we have come, and this is how the treatment paradigm starts, and this is how it looks as far as EGFR, ALK, ROS. But what we're going to be focusing on today is the BRAF positivity, or specifically the BRAF V600 E and K positivity, where we have BRAF and MEK inhibitors that are currently approved as well, which are dabrafenib and trametinib, which are currently available in India as well. So let's just understand a bit more about the pathway before we actually get into it. This is the EGFR signaling pathways that normally happens. What happens is the downstream signaling pathways are active from EGFR to RAS, BRAF, MEK, and MAPK and ERK. So that's how the downstream signaling pathways act. So the BRAF kinase mutations actually result in constitutive and also activation and uncontrolled signaling via the MAPK pathway. So I think, and when we talk about BRAF mutations, we talk about cutaneous melanomas, where about 50% can have BRAF mutations, and in colorectal carcinomas about 10%, thyroid around 30 to 50%, in non-small cell, at baseline it's around 2%. So that's just to give you an overview about the incidence of BRAF mutations. It's seen in about 1 to 4% of all adenocarcinomas of the lung. And they're mutually exclusive as well. They don't coexist or overlap with the other common mutations. This is the general rule of thumb, where EGFR, ALK, and KRAS, they're all considered to be mutually exclusive, not always.
And they do not appear to correlate strongly with age, sex, or the stage of diagnosis and the status of smoking. And even though there are some studies which have looked at showing that these BRAF mutations are more likely to be seen in female patients or in patients who actually have a history of smoking. And if you look at the particular transcripts that are most common, the V600E seems to be the most common across the board, even in non-small cell lung carcinoma as well. So that accounts for about 50 to 70% of all the cases. It's caused by a point mutation in the BRAF kinase domain at the position 600, where the valine is substituted to glutamic acid. And what we've seen or heard earlier from these BRAF V600 mutations is that it definitely predicts for a shorter median DFS and overall survival. So worse outcomes are seen in these patients even with your regular or routine platinum-based chemotherapy, as opposed to wild-type patients, and that's depicted from this slide as well. And we know that their outcomes are particularly poor with platinum-based chemotherapy, as opposed to patients who are wild-type. And look at both in terms of response rates, median PFS and median overall survival, much lesser in the BRAF mutant cohort, as opposed to the wild-type cohort. And the treatment also always remains suboptimal for patients who have a BRAF V600E mutation. And this is just data to point out about 1/3 of these patients only receive best supportive care as first line, about 2/3, around close to 60%, receive best supportive care as the second line option. And a doublet-based chemotherapy seems to be the most common treatment option in a BRAF mutant non-small cell lung carcinoma. That's changed now with the current approval, where we have dabrafenib and tamitinib and the data from the study, which I'm just going to be alluding further on. So upfront BRAF testing, yeah, definitely that's part of the recommendations from the NCC and the ESMO. All the guidelines recommend that you will have to definitely look at doing a BRAF mutation upfront itself, and a broad-based molecular profiling will help us identify much more actionable driver mutations as far as the non-V600E and K mutations are concerned as well. And the type of progression definitely drives our choice of therapy when it comes to EGFR mutant non-small cell lung cancer. So we talk about oligoprogression or CNS oligoprogression, where we look at just doing local therapy and addressing the brain met. And if the extracranial disease is well under control, you could even continue with the same EGFR TKI. If somebody's got an indolent progression, you could even look at continuing beyond progression. But if somebody's got a rapid progression, then you would definitely look at getting a repeat biopsy, checking out, understanding the mechanisms of resistance, out of which small cell transformation is one of the mechanisms of resistance. If that seems to be the case, then you'll have to switch over to a etoposide platinum or a platinum-based doublet chemotherapy. So what then are the mechanisms of resistance? Well, we know that the T790M mutation is the most commonest mechanism of resistance as far as an EGFR mutant non-small cell lung cancer is concerned. The other mechanisms being the alternate signaling pathways getting amplified, like the MET pathway, and then you have small cell lung cancer transformation in about 5 to 10% of the cases, and in the rest you have EMT or epithelial mesenchymal transformation. And mind you, these are all only secondary resistance mechanisms. And the one primary mechanism of resistance is a KRAS mutation, which can be coexistent as well. Even though I told you that they are mutually exclusive, in about 1% of patients, they can have a KRAS mutation. Recently, we've had an example as well where we had a patient who progressed within a month on an EGFR TKI, and subsequently we figured out on NGS that the patient has got a KRAS mutation as well. And that probably is one of the primary mechanisms of resistance to EGFR TKI. So how then do you check for it? Ideally, a tissue-based sampling would be the best, because that's when you can identify the transformation to small cell lung carcinoma as well. But then if tissue is an issue, like we always talk about, then plasma is the next best choice. So you'll have to look at identifying all these amplifications, MET, HER2, and then the BRAF as well, which is probably much more relevant if you do it on tissue, but it can be done on NGS. I'll tell you about the highlights and the drawbacks of that as we move along. Pik3 mutation, KRAS, EGFR, and then RB1 P53 loss as well. So when we talk about treating resistance to first-line osimertinib, well, we know even in patients who have an exon 19 deletion, well, and even if they're on if they are on a first-line osimertinib as well, they can actually develop exon 20 C797S mutation. And it's not just knowing the mutation, but also knowing whether it's a trans or a cis mutation. That also really matters, because those who have a trans mutation actually seem to respond to a re-challenge with a first-generation TKI or a combination with osimertinib. And those who have a cis mutation seem to respond to VEGF inhibition, where you could look at adding bevacizumab to your TKIs. So I think that's one way of looking at it. But looking at BRAF, Again, the estimated frequency, like I was telling you about, is around 2%. Even in patients who have as a mechanism of resistance to EGFR TKIs, well, it accounts for around 1 to 2%. And I think these are the types of BRAF mutations that we talk about. We have class 1 mutations, out of which V600E and K are prime examples, and then the class 2 and 3, which are non-V600 mutations. So when you do an NGS or a broad-based molecular profiling, you actually end up picking any of these other non-V600E mutations. So what do you do then? We know that the drugs are approved only in V600E and for melanoma in V600K as well. So I think that's one caveat. What do you do if you pick up any of these non-targetable BRAF mutations? We don't have a pan-BRAF inhibitor yet. That's all in the pipeline. So the most common exons as far as BRAF is concerned are exon 15 followed by exon 11. Just as we talk about V600E followed by V600E, most commonest exons are exon 15 followed by exon 11, and class 1 seems to be the most common as well. So why then do you have to combine a BRAF and MEK inhibitor when you look at targeting this as a mechanism of resistance? Why not use only a BRAF inhibitor? So what happens is, like I was showing you earlier, the downstream signaling pathways, when you only block the BRAF pathway, the downstream signaling pathways become more active. There is overexpression of MEK, and that can lead on to squamous cell carcinomas of the skin or skin cancers. So to prevent that from happening, you combine a BRAF with a MEK inhibitor, which actually is synergistic and also prevents MEK overexpression. And this is the currently available BRAF and MEK inhibitor that we have, dabrafenib plus trametinib, available from Novartis. And this is the DCGI approved indication, albeit even in the first line setting. And I'll show you the data for that in patients with a BRAF V600 mutation. And this is the approval is based on this phase 2 study, which looked at patients who were pre-treated and pre-treated with the combination and pre-treated only with the monotherapy of dabrafenib alone, as opposed to dabrafenib plus trametinib, and who had treatment naive as well, where this combination was looked at. The numbers were pretty small, obviously, given that it's only a stage, it's a phase 2 data. The endpoints being overall response rate, secondary endpoints, PFS, duration of response, overall survival. So just to summarize the study design, the phase 2 data looked at around 170 patients, primary endpoint being overall response rate, had 3 cohorts, pre-treatment patients with only monotherapy with dabrafenib, pre-treatment patients with the combination of dabrafenib plus trametinib, and treatment naive patients with a combination as well. And well, as you can clearly see here, cohort B, the response rates, and in cohort C as well, that is both in the previously untreated and in the previously treated, the combination actually did much better as opposed to just a monotherapy. And how do you then manage the most common adverse effects with this drug? Well, the most common adverse effect seems to be pyrexia, which can be managed with treatment interruption if the patient has persisting temperature more than 101. And you could look at continuing a trametinib, and you'll have to look at using antipyretics like paracetamol as well. And then finally, if it becomes grade 2, more than grade 2, then you'll have to look at using oral steroids as well. Dose reduction in this fashion, you start with 150 milligram twice daily of dabrafenib and 2 milligram once daily of trametinib. Lowest possible dose being 50 milligram twice daily for dabrafenib and 1 milligram once daily for trametinib. So again, to understand how do you look at targeting BRAF mutation as a potential pathway of resistance to EGFR mutant non-small cell lung cancer, there are a host of ongoing trials looking at this combination in addition to osimertinib or in addition to the other drugs as well. But we don't have the data from those studies yet. So that's still in the pipeline, and that's exciting times ahead as well. So with that, I'll conclude and say thank you all for your patient listening. Hand it over back to the organizers.
Thank you, Dr.
Sorry, sir, please go ahead.
Nice presentation. And now I will request my co-chair, Dr. Anupriya, to introduce next speaker.
Thank you, sir. For the next talk on role of brigatinib in ALK-positive non-small cell lung cancer, previously treated with other TKIs, I would like to invite Dr. Kshitij Joshi. Over to you, sir.
Thank you very much for giving me this opportunity. I will request organizer, can you please share slides? So it's a big responsibility for me to present this after Dr. Krupa Shankar's excellent presentation, but I will try. So can somebody share? Yeah, after the excellent lecture by Dr. Deepak Gupta sir about lorlatinib in ALK positive NSCLC, going back to brigatinib will be a little different, but I will try to put forward the facts about the brigatinib that is available in front of me. So the topic of today's lecture is the role of brigatinib with ALK positive NSCLC previously treated with the other TKI. Next slide. So this is a slide that you have already seen. 7% of tumors of NSCLC are ALK positive. Next slide. We have moved from one mutation, one test to one patient, one test like NGS, and we come to know all this mutation nowadays. Next slide. So the ALK inhibitors, as we are aware, first generation crizotinib, second generation ceritinib, alectinib, and brigatinib, and third generation lorlatinib. Next slide. And the evolution that already shared with us, here I just want to point it out, the crizotinib was first approved in 2011, and 2017, brigatinib was approved, progressive disease on or intolerant to crizotinib. And then it was ALTA 1L trial. They show the first line brigatinib better than crizotinib in 2018. Next slide, please. So what is brigatinib? It is a second generation TKI. It inhibits ALK fusion, mutated EGFR L858R and ROS1 fusion. It inhibits all 17 known resistant mutation of ALK, 12-fold greater potency, better CNS efficacy than crizotinib, and better tolerability. Next slide. So here is a comparison of different trials, crizo, ALK, ceritinib, and brigatinib. Here we can see the overall response rate is 71% with the brigatinib. Next slide, please. And median PFS not reached. So here is a comparison of different mutation. So here, actually, this is a slide which is showing the lorlatinib benefit. It has shown almost has a broad spectrum potency against most known ALK resistant mutation, including ALK G1202R. But brigatinib, if you compare, except for a few more, it is almost similar. Next slide. This is ceritinib. Next slide. Next slide. Okay. So from where it was started, the brigatinib was in crizotinib refractory ALK positive NSCLC was tried in ALTA trial. Next slide. The brigatinib for crizotinib refractory ALK positive NSCLC, the background was progression after crizotinib treatment, typically ALK positive NSCLC because of acquired ALK resistance, mutation, poor penetration to CNS, and secondary ALK resistance also developed with current post-crizotinib ALK inhibitors. And the brigatinib was a potent ALK TKI which activity against common resistant mutation including G1202R, survival enhanced versus crizotinib, and tumor burden reduced in the orthotopic brain tumor model. And the multicentral open label single phase 1 and 2 study demonstrated anti-tumor activity of brigatinib. So next slide. So this study design was brigatinib 90 milligram versus brigatinib 180 milligram dose. It was almost similar 112 versus 110. The patients were divided locally advanced or metastatic ALK positive NSCLC. And the primary endpoint was confirmed overall response rate. And secondary endpoint was ORR by IRC and intracranial ORR and PFS OS. Next slide. And here we can see overall response rate. The confirmed ORR after prior CT was 42% with 90 milligram and 54% with 180 milligram. And one confirmed PR with 180 milligram, patient with a baseline G1202R. Next slide. The PFS we can see 9.2 months versus 12.9 months in 90 milligram versus 180 milligram. Next slide. The OS also we can see it is 1 year OS probability is 71% versus 80% more in 180. Next slide. And the conclusion of this ALTA trial was brigatinib at 90 milligram or 180 milligram is active and tolerable in ALK positive NSCLC. Median PFS over 1 year at the higher dose. Intracranial activity in patient with measurable brain mets. Study investigator conclude that brigatinib is a promising potential option for crizotinib resistant ALK positive NSCLC. And ALTA 1L trial was then started, randomized phase 3 study of brigatinib 180 milligram regime versus crizotinib in patient with ALK inhibitor naive ALK positive NSCLC. Next slide. So this is ALTA-1L trial. So brigatinib versus crizotinib in TKI naive ALK positive NSCLC. The 3-year PFS by blinded independent review committee was 43% with brigatinib versus 19% with crizotinib. So median is 24 versus 11. And the median overall survival was not reached in either group. Next slide. The post-hoc analysis suggested that overall survival benefit for brigatinib in patient with baseline brain metastasis with HR 0.4% or 0.43, and brigatinib exhibits superior efficacy compared with the crizotinib regardless of a EML ALK variant and T53 mutation. Emergent secondary ALK mutation were rare in patient progressing on brigatinib. That is also important. And no new safety signals were observed. Next slide. So on the basis of that the drug was approved, then brigatinib in alectinib refractory ALK positive NSCLC. Now the second generation ALK inhibitor alectinib recently showed superior efficacy compared to the first generation ALK inhibitor crizotinib in advanced ALK rearranged NSCLC, establishing alectinib as a new standard of first line of therapy. Now brigatinib, another second generation ALK inhibitor, has shown substantial activity in patients with crizotinib refractory ALK positive NSCLC. However, its activity in alectinib refractory setting is unknown. Next slide. So this study was designed, the number of patients was limited 22 patients. Confirmed objective response rate to brigatinib were observed in 3 out of 18 patients, 17% with measurable disease, and 9 patients, which is 50%, having stable disease on brigatinib. The median PFS was 4.4 months, 95% confidence interval. 1.8 to 5.6 was the range, and the median duration of treatment was a 5.7 months. And here we can see the very less number, out of which 9 patients underwent post-alectinib pre-brigatinib biopsies. 5 had ALK I117X1X and V1180L resistant mutation, and 1 had confirmed partial response, and 3 had a stable disease, and 1 has a G1202R mutation in post-alectinib pre-brigatinib biopsy and has progressive disease, as the best overall response to brigatinib. Next slide. So what was the conclusion of post-alectinib trial? The brigatinib has limited clinical activity in alectinib refractory ALK positive NSCLC. Additional studies are needed to establish biomarker of response to brigatinib and to identify effective therapeutic option for alectinib resistant ALK positive NSCLC. Next slide. So now there is one trial which is ongoing, brigatinib versus alectinib, that is a crizotinib resistant second line setting, advanced ALK positive NSCLC, ALTA-3. They are randomized as a brigatinib 180 milligram versus the alectinib 600 milligram twice, and approximately 246 patients will be enrolled and PFS will be assessed. Next slide. The second endpoint or overall survival and safety endpoint assessment will be done, and conclusion of this trial will tell us the ALTA-3 trial will provide important comparative data of safety and efficacy of brigatinib compared with alectinib in patient with a locally advanced metastatic ALK positive NSCLC that has progressed over crizotinib. The results will help to define optimal ALK inhibitor sequence after progression on ALK TKI therapy. Next slide. So after arrival of lorlatinib, everything is changed, but I just want to give you an idea where we stand today. The biomarker integration in the management of patient, second and third generation, if you started with alectinib, the mutations here are V1180L, and the ceritinib, brigatinib, and lorlatinib are option. We start with the ceritinib, we have alectinib, brigatinib, and lorlatinib option, and we start with the brigatinib, E1210K, S1203N, E1210K, and S1206C. Then the mutation lorlatinib is the only option. And if you have a 1202R mutation, then the lorlatinib is option. And if you start with the lorlatinib, then the crizotinib that we can see. Next slide. So what NCCN says in 2022, whenever there is a rearrangement positivity, preferred first-line therapy is alectinib category 1 indication. Brigatinib is also a category 1 indication based on the trial that we have discussed. Lorlatinib is also category 1 indication. So sir has first discussed giving the best drug first, maybe at the best criteria, but still there is all these three are the category 1 indication as per the NCCN. And other recommended regime, they mention ceritinib, and useful in certain circumstances, crizotinib. Next slide. And here in the second line, that was a topic of discussion, progression on first line TKI. If the TKI is either alectinib, brigatinib, or ceritinib, or lorlatinib. If the asymptomatic progression, we know local therapy with consideration of the continuation of the same. If the symptomatic brain progression, we also do a local therapy and continue alectinib or brigatinib or ceritinib or lorlatinib. For G1202R mutation, lorlatinib is the option, and the systemic, we have a either we can use a second generation or a third generation TKI. Okay, and next slide. So ultimately, it is all about how far you run. So here, I just want to try to show you, depend on the various trial, the sequential strategies. If you start with the crizotinib, chemotherapy, the 7-month crizotinib has given us a 10.9. Then Ascent 5 has shown ceritinib as 5.4 months. And the Allure trial has shown that alectinib as 9.6 months as a second line. Alta trial has shown as brigatinib as 12.9. And now the lorlatinib trial has shown this is what is the highest one. And the third line, we have only lorlatinib as a 6.9. So here we can see brigatinib stands very important role in a progression over the first line TKI. So this is what I just want to discuss in short. I think in discussion, the rest of this, the panelists will give us a better idea of the current situation. The next slide. Okay, thank you very much. And thanks organizer for giving me this opportunity to present this lecture in front of you. I hand over to organizer.
Thank you, Dr. Joshi. And now I will invite to the next speaker. Next speaker is Dr. Ghanshyam Biswas, and he will speak on is resistance to salpersatinib and pralasatinib mediated by the non-gatekeeper RAT mutation.
Thank you, sir, and thank you, Icon, for the opportunity. So Lalita is smiling. Kashish, slides.
So Dara, you are always.
Sure, so we'll just share the screen.
So thanks for an opportunity again. So I will just confess that I have borrowed slides from one of the big lung cancer treatment person, Dr. Vivek Subbiah. So my topic is resistance to sulfatinib and pralasatinib mediated by non-gatekeeper RAT mutations. Next. So a RAT is the transforming proton oncogene that encodes a receptor tyrosine kinase and was accidentally discovered in patients with a T-cell lymphoma upon transfecting human tumor DNA with the rearrangement by Takashi et al. Almost 3.5 decades back. The receptor tyrosine kinase RAT is involved in the fetal development of nervous, hematopoietic, gastrointestinal, and the genitourinary systems. So a kinase inhibitor with enhanced specificity for RAT tyrosine kinase receptors, so RTKs, over are the RTK classes. Enhanced RAT, that is rearranged during transfection, oncogene expression is a hallmark for many cancers. So the drugs we are talking about are specific RAT inhibitors. So they are pralasatinib and the sulfatinib got FDA approved subsequently, represent the first generation of these specific RAT RTK inhibitors for the treatment of RAT-driven cancers. Next. So if you look at the genomic of lung cancer drivers on the left-hand side, so we are not talking about this sometime back before, so the ADURA trial came in. So in early stage lung cancer in a non-small cell, if you see, the RAT fusion is to the tune of 0.3%. If you are talking about an advanced non-small cell lung cancer, the same RAT fusion from 0.3, it becomes a 2.3%. Next. So what is the function of this? So rearranged during transfection, that RET is a transmembrane receptor tyrosine kinase which have an extracellular, transmembrane and an intracellular domains whose activity is required for the normal renal and a nervous system development. This constitutive RET activation is achieved through a chromosomal rearrangements, produce 5' fusions of a dimerizable domains to the 3 RET tyrosine kinase domain, leading to constitutive dimerization and subsequent autophosphorylation. So with this dimerization, so what happens? The constitutive RET activation actually increases the downstream regulation or signaling, and that actually leads to a tumor invasion, migration, and a proliferation. Next. So the RET is activated by 2 major mechanisms in cancer. So on the left-hand side, you can see a RET fusions. So predominantly in non-small cell lung cancer and in thyroid cancers, papillary thyroid cancers. The other group is a RET mutations, which happens in a medullary thyroid cancer. So be it a sporadic or a part of hereditary like Menon syndrome. Next. So the RET fusions, which is seen in lung cancer. So adenocarcinomas are the most frequent histology, followed by adenosquamous, squamous cells, and then the neuroendocrine cancer. So they tend to occur in a relatively younger age group, never or a light smokers, like the EGFR and the ALK. So like the other common driver, RET fusions, so like the EGFR and ALK, so they tend to occur in a mutually exclusive fashion, yet they might be acquired in some patients who become resistant to EGFR therapies in EGFR mutated in non-small cells. So that brings us to a repeat biopsy on a progression on those who are on anti-EGFR. Next. So coming to RET mutations, in contrast to a papillary thyroid cancer where RET fusions are seen, mostly medullary thyroid cancers carry RET mutations. So RET point mutations which occur as a germline or a somatic mutations are found in families with MEN2. So you know that MEN2 is an inherited cancer with so many other cancers like pheochromocytoma and parathyroid. Next. Next. So a number of oncogene RET, just go back. A number of oncogenic RET fusions and activity point mutations have been identified to date. On the left-hand side, in the RET fusions, if you talk about most common in non-small cell, it is a KIF5B. And in the PTC, that is primary papillary thyroid cancer, is a CCDC6. And in the RET point mutations, so they're in the medullary carcinoma thyroid. So these are the mentions. Next. So if you see what happened in COVID pandemic, so you know that, so there are so many approvals. So from May 6, 2020, you can see there are 10 odd approvals itself in a non-small cancer space. So May 9, 2020, so this RET inhibitor, that is selpercatinib, RET fusions, and almost a few months later in September 4, so the other drug in the same class, in the same generation, so paracetamol and the RET fusion actually got approved. Next. So the oncogenic RET alterations identified, so way back in 1985, and when the RET was equivalent to a RET RTK, then papillary thyroid cancer, then medullary, then CMA. Now we are talking about lung adenocarcinoma, and there's so many cancers. But 2020, after that, so we had the first drugs of selective RET inhibitors, as I said. Next. So what happened to multi-kinase inhibitors? So before the RET specific drugs, so we didn't have any superheroes. So the MKIs in the RET altered non-small cell lung cancer, if you look at the responses and the PFS, so they were definitely lower than that what we saw with ALK inhibitors and ROS in those respective cancers. But if you see the responses in these patients with a platinum base, so they are almost equivalent. So these were lenvatinib, vandatinib, and cabozantinib. Next. So the RET fusion in non-small cell, as I said, so probably a pemetrexed based doublet before these drugs were available with a response rate of 45 to 50% and a median PFS of 19 months. RET rearranged lung cancers have low levels of PD-L1 and low TMB, So thereby, these are actually a cold tumors in the majority of patients, and hence they are not responses to immune checkpoint inhibitors. Next. So if you see this drug, the first of its class, which got approved initially and got published in NEGM at the same time last year. So the selpatinib, if you see the phase 1-2 trial, so there are almost 144 patients. So in one group where previously platinum-based was already used, 105 patients, in the treatment name, around 40 patients were used. In the previously treated patients, you can see a response rate which included complete and a partial of 64%. Whereas the newly diagnosed patient with the RET fusion, so almost 85% responses. So the median duration of responses was around 1.5 years. Next. And if you see the trial of from which this FDA got approved, this drug, so the Palliative, so from the ARROW trial, which showed in a platinum exposed chemotherapy, the response rate was around 60%. Next. So every drug has its own, because of resistance. So the data on acquired resistance to RET-specific inhibitors are rapidly emerging, but that is not fully understood. However, recent studies have suggested that on-target mutations at non-gatekeeper sites or emergence of off-target alterations such as MET amplifications or NTRK fusions, which can be seen in almost 1 to 1.5% as a mechanism of acquired resistance, and this can be picked up only on a repeat biopsy. Next. So the structural basis of acquired resistance to sulfatinib and pulsatine mediated by non-gatekeeper RET mutation, that is on-target resistance. So if you see that, so resistance to these drugs are found at the solvent front and the hinge site of the RET kinase domain. So we'll see in the subsequent slide. Next. So if you see this cartoon on the upper side, so these are the two selective RET inhibitors, and if you see this RET tyrosine kinase, so this has an extracellular, this has a transmembrane and intracellular. So as I said, so the mutations happen in the solvent front, you can see on the left hand side, and the mutations can happen in the hinge side. So the mutations can involve the binding selective RET inhibitions, and thereby, so there can be a mutant RET, so probably, and the downstream pathways get affected, and probably this is the mechanism for, as marked red, for a RET resistance. Next. So restoring the balance for cancer care in the COVID-19 era. So probably it's time that Omicron is out, and probably we are in a super pandemic of the Russia and Ukraine crisis. Thank you so much.
Thank you so much, sir. I now request Anushri ma'am to please introduce our next session.
Thank you, sir, for this wonderful talk. Now for the next session on dissecting 5-year outcomes from the randomized phase 3 trials, Checkmate 017 and 057. I would like to invite Dr. Amit Pradhan. Over to you, sir.
Thank you very much. Good evening, everyone. I thank the organizers for giving me this opportunity. So my topic is dissecting 5 years outcome from the randomized phase 3 trials, Checkmate 017 and 057. That's nivolumab versus docetaxel. Very important trials, 2 trials which brought immunotherapy into the lung cancer space. And with this, immunotherapy was first approved in lung cancer in progressive disease. So this was a study design. These were patients who had stage 4 lung cancer, non-small cell, which had progressed on first-line platinum chemotherapy. The Checkmate 017 was looking at the squamous cell population, while the Checkmate 057 was looking at the non-squamous population. All these patients had progressed on 1 line of chemotherapy. They were randomized 1:1 to nivolumab versus docetaxel, and docetaxel was the standard of care at that time. So the primary endpoint was overall survival, and there were very secondary endpoints of PFS, overall response rate, and safety and patient-related outcomes. Now, this is a pooled analysis which we are seeing of both these trials at 5 years. follow-up. The median follow-up was 69.5 months. It's actually more than 5 years, the median follow-up. What we saw, the overall survival, now we had seen the median overall survival long back. It was 8.1 months versus 11.1, which is with a hazard of 0.68. But what you see is at all time intervals, that be it 1 year, 2 years, 3 years, 4 years, and 5 years, there are a larger population of patients living with nivolumab versus docetaxel. And at 5 years, if you see, docetaxel had a 5-year overall survival rate of 2.6%, and it was 10% higher at 13.4% with nivolumab. So clearly, there's a segment of population who's doing well in the long term and continue to survive when they were treated with nivolumab. Now, the overall survival was analyzed in different populations. If you look at the squamous cell population, the top left, again, the similar differences in the curves, hazards of 0.62. And at 5 years, you see 3.6% versus 12.3% patients surviving with nivolumab versus docetaxel. Even in the non-squamous population, the hazards were 0.72, again, 2.1 versus 14%. So you're clearly seeing 10 to 12% per patients more surviving at 5 years follow-up. The PDL1 greater than 1%, again, at 5 years, we see a clear difference between the two arms. And even in PDL1 less than 2%, less than 1%, there's a difference. It is a little lesser, but it is still statistically significant with a hazard of 0.76. So clearly the benefit is there in both the PDL1 greater than 1% and the PDL1 less than 1%. The quantum of benefit is more in PDL1 greater than 1%. But again, we know that even PDL less than 1% are benefiting. And that's why this approval for nivolumab in the second line setting was without PDL1 status. And that's why we don't really need to check PDL1 in the second line setting. If you see the forest plot of the overall survivals in predefined subgroups, again, the benefit was seen across all the populations, whether patients had liver mets, whether patient had bone mets, whether patients had, the only population which didn't show that much benefit was the never smoker population, which was a smaller population in this study. Current and former smokers clearly showed a significant benefit. Response rates, nivolumab versus docetaxel, 11% docetaxel versus 19.7% with nivolumab. Again, most of these responses are all partial responses. If you look at progression-free survival, now at 5 years, so when we look at medians of PFS, you see a difference which is very, very small. They're almost touching each other, the curves, but the separation starts later. And actually the separation comes after 6 months. And that's why you don't see an improvement in the median PFS. When you see it numerically, you always feel, oh, nivolumab is not doing great. But you start seeing the separation after 6 months, and then you see the sustained separation. So what we saw, nivolumab, at 5 years, 8% patients are progression-free, while in the docetaxel, it is 0%. And in docetaxel, it became 0% after 3 years. All patients progressed. Here, what happens at 3 years, it was 10%, 4 years, 9%, 5 years, 8%. So we hit a plateau in the curve. And that's what's the impressive part of immunotherapy. Once you respond, you can have a sustained response. And that's what you're seeing from these PFS curves. You can also look at it the other way, duration of response. Now, 20% of patients benefited with are the ones who responded. And if you analyze these patients with duration of response, what you see clearly, there's a big difference in the median duration of response. 5.6 months with docetaxel versus almost 20 months with nivolumab. A clear separation of curves. And if you see how many patients are responding at 2 years, 3 years, 4 years, and 5 years, you clearly see there's a big number responding. But in docetaxel, those patients who progressed by 3 years, after that, there's not a single patient who's not progressed. Everyone has progressed and 0%. The PFSs were also analyzed according to whether they're squamous and non-squamous. And again, we see the clear difference, the PFS of nivolumab being much higher at 5 years, 9.4% versus there was hardly anyone in docetaxel. And then again, the same way, 7.5% in adenos versus 0% in docetaxel. If you looked at PDL1 status in the PFS, again, greater than 1%, PDL1, there is a benefit. In PDL1 less than 1%, the PFS benefit was not seen statistically. If you look at duration of responses, again, in squamous and non-squamous population, clearly the same differences. Both the populations, nivolumab patients at 5 years, there's about 34% of patients, more than 30% of patients who are continuing to respond versus 0% in squamous cells, in the docetaxel arm. Again, if they looked at it by PDL1 status, they see the same thing at 5 years. Duration of response continues even in the PD-L1 positive and the PD-L1 negative population. Clearly, again, telling us PD-L1 does not matter. If you respond, you can have sustained response. They had a type of analysis here, which they showed at 5 years. What they said was, if you looked at patients who have PFS in the nivolumab, if they did not have a progression at 2 years, there were 45 patients, then there's a chance at 5 years, 59.6% of these patients did not have a progression. If 3 years, the population was about 29 patients, the chance of being not progressing at 5 years was 78.3%. And at 4 years, if they did not progress, then 87.5% did not progress at 5 years. Again, this is just reflecting the same thing in different ways, that if you don't progress after 2 years, 3 years, your chances of progression are much lesser. They looked at survivors at 5 years. In nivolumab arm, 50 patients were surviving at 5 years. In the docetaxel, only 9 patients were surviving at 5 years. Out of the 50 in nivolumab, 21 had progressed, 21 did not progress. Those who did not progress, 16 were continued to be on nivolumab. So 5 of them stopped nivolumab. In those who progressed, they were rechallenged with treatment, and 7 of them actually received immunotherapy again, and 12 received other lines of therapy. In the docetaxel arm, 8 progressed, 6 of these received immunotherapy again out of the survivors at 5 years. So clearly we're seeing the big population compared of nivolumab versus docetaxel surviving at 5 years. This is a swimmer plot of the 50 patients who are surviving in the nivolumab arm versus the 9 patients who are surviving in the docetaxel arm at 5 years. What happens to the adverse events? The total adverse events, 67% treated with nivolumab experienced some amount of adverse events. But if you look at grade 3 and 4 events, it's about 10.8%. If you look at the type of adverse events and the timing, what we see here is most of your adverse events happen in the first year. Some new ones happen in the second year. But after 3 years, hardly any new immune-related adverse events are happening, even in those patients who are continuing greater than 4 years. So clearly telling us when you use immuno, in the initial few years, initial few months is maximum when you develop these adverse events, immune-related. Though we need to be watchful, careful over the long run, but there are very less chances they will develop newer adverse events in the long run. So my thought was, how does this hold on with our Indian patients? Does this work as well as what we talk about? So just to show a couple of cases, here's a 76-year-old male, lung cancer squamous cell, stage 4, diagnosed in April 2018. He received weekly nab-paclitaxel carboplatin and he progressed, and that's what's his lung status, left lung mass in 2018. He gets nivolumab, and after 8 doses nivolumab, you see the lung, the left side, clear, dramatic response. He gets into a very good PR. It was not complete CR, but a very good PR. And we stopped treatment at 1 year. That's 16 doses that we finished, and we stopped by April 2019. But he continues to be remission even now. It's December 2021 when we assessed him. He's 44 months down the line. So clearly telling us that when patients respond to immuno, they can have this dramatic long-term response, and they may not even require continuous therapy as sometimes suggested that it needs to just go on and on. It may not be true for all patients. Here's an 87-year-old lung adenocarcinoma, stage 4. March 2018, right lung mass, gets nivolumab. After 12 doses, that's his scan. He stops treatment in 1 year after 20 doses of nivolumab. And even now, after 45 months in December 2021, he continues to be remission. So telling us the same thing, even if it's an adeno, if it's a squamous, if they respond to immunotherapy, there is a potential for this long-term response. So the conclusion of this study, 5 years outcome demonstrates that nivolumab can provide long-term survival benefits, and these can be very durable responses. The safety profile is very tolerable, and new safety signals are not seen even in long-term use. And some patients appear to maintain prolonged disease control even after systemic therapy. And that's something I would like to kind of take home for me, is this, that if you get response and you can get sustained response, maybe we don't need to be on continuous therapy for long term, and we can have patients who stop therapy and continue to do well. That way it's more financially viable also. But again, the response should last for a long time is what we're looking for. We're clearly seeing how our lung cancer patients are doing better from these studies and also from our clinical practice. So I thank everyone for this patient hearing. Thank you.
Thank you so much, sir. We'll now move to the panel discussion. I request Dr. Dr. G.S. Bhatti, sir, to please introduce our moderator and our Tumor Board 1 members.
Thank you, Dr. Amit, for excellent presentation as usual and smiling and full of happiness always. Thank you very much. And now I will invite the Ullas Batra, well-known master in lung classes, and he will moderate the session and he will invite his members of the Tumor Board. Thank you.
Okay, here we go. Thank you, sir. And it's nice to see it's approximately 9 o'clock and we still have around 75 odd people. That is the charisma of Dr. Hemant Malhotra and Dr. Lalit Mohan Sharma, I guess. Everybody
they are awake as well. Ullas, they all are awake as well.
I know. I mean, sir, that is not to be seen, sir. Uske liye sir camera on karna padega, sir. Okay. So can I, because I have been given a list of 12 panelists, can I request my panelists to, okay, yeah. We have Dr. Neha Sethi, Dr. JP Agarwal, Dr. Ankur Punia, and Dr. Sachin Jain. Yes. And I would request anybody else also who is awake and listening to participate in the panel. And again, you know, when I was asked to moderate about the MDT meeting on lung cancer and lung injury, my first reactions, you know, I mean, when somebody asks you to moderate a panel discussion on lung cancer, it's like, okay, fine, I'll do. And I think, you know, that is what they want to discuss. Like, you know, Dr. Amit Proton very nicely showed 5 years, 10 years, you know, about 16% of thing. And, you know, what we normally discuss in lung cancer is, you know, that they lived happily ever after. If you had a biomarker, you gave TKI. If you have a PDL1, we gave Pembro or Nivo, and they lived happily after. My subsequent reactions after I went through the topic again, and that was yesterday night, was that is not what they want to discuss. They actually want me to discuss the post-Valentine's week. They basically want me to discuss happily ever after is a myth. Life is not a fairy tale. It will never be. So I am going to tell you something, and I'm going to take out, you know, I'm sure all the pharmaceutical companies don't want to hear this. And I'm sure this is going to be fun. This is really, and going by the Dr. Sachin Jain's reaction, you know, initially it was aram se cold, calm, composed, now okay, fine. Ye bhi batana tha. So we'll be discussing about the toxicities of lung cancer. And for the first panel, I'm going to call up, I mean, there is, this is the case that I have. We have a 65-year-old male. She has a history of breathlessness, cough with expectoration. She was diagnosed as EGFR mutant non-small cell lung cancer. She had a pleural effusion also, and ECOG PS was 2. This patient, this is the name, I have not seen the patient till now. I told, you know, this report was given to me and I asked the patient to bring them over there. She's a known case of coronary artery disease, scleroderma, rheumatoid arthritis, hypothyroidism, DVT, pulmonary embolism, pleural effusion, and lung cancer stage 4. So when the attendant, and the one more side effect which I have not mentioned is a very hyper attendant. I mean, that is not supposed to be said. She was also on multiple polypharmacy, which included drugs like mycophenolate, mofetil, and HCQS. The PET scan was done, and the PET scan, if you can read over here, so, you know, was suggestive of ill-defined mass, contagious with collapse consolidation. There was some thromboembolism. There was a loculated left pleural effusion. There was a mild right pleural effusion. There was pleural thickening, and there was this interlobular septal thickening left upper and lower lobes, possibly lymphangitis carcinomatosis. However, an ILD-like features could not be ruled out. That is what they told me over there. These are the pictures. This was the CT scan that was there. You can see a mass over here, and in here you can actually see some ground glass opacities. And also remember, this was the COVID season going on somewhere in the month of November. So with this, Dr. Sachin, what would be your treatment of choice? Will you like to give third generation, second generation, first generation? If Kumar is there, Dr. Kumar is there, I have named a new regimen, which is called as a KN regimen, which is basically the Kumar Naronoha regimen, which is the Tata Memorial regimen. The Brave regimen, I have said, that is the ABCP. The Mango Man regimen, I am from Delhi, only chemotherapy. And will a past history of scleroderma change your decision? So Sachin, first to you.
So in my current practice, I will go with first generation TKI, sir.
First generation TKI. And the reason for that, and if it was an Astra symposium?
Yes, sir.
If it was an AstraZeneca symposium, then
sir, as per the availability, easy availability and affordability,
money is not an issue. Money is not an issue.
Much more comfortable with. Still, we are more comfortable with first generation TKI. That's
so
why.
money is not an issue. Forget money.
Then the latest with the latest medications, we can.
You will want to go with the latest medication. Fantastic. And Ankur?
Sir, my preference would be go with the third generation TKI. Because the concern with us is the patient has multiple comorbidities, which might be like the patient already has some ILD-like changes. And patient with multiple lung comorbidities as well is prone for multiple more progression of whether that's ILD or a disease. And in the TKI data, with the recent generation, the percentage chance of ILD is less with third generation TKI if you compare to the first and the second generation. So definitely I would prefer a third generation TKI, and a chemotherapy in a particularly this kind of patient. I would be much more easy, comfortable with the TKI rather than a chemotherapy regimen.
Okay. You don't want to give the KN regimen. I'm going to come to Kumar also. You don't want to go to the KN regimen. You don't want. Fantastic. Okay. Neha, Dr. Neha Sethi is there.
Yes, sir. I'm there.
Dr. Neha.
Yes, sir.
What would your choice of treatment be?
Sir, this depends on the oncologist as well. I am a pathologist actually.
Okay, fantastic. So, Dr. Neha, I have some questions for you also. We will just keep it. We will just keep it to us right now. I'm so sorry to get you here right now.
Okay,
Dr. JP Agarwal also is there. Although I mean, it doesn't concern his field of interest right now, but it's always fun to listen to Dr. JP. Dr. JP, any preferences?
Yeah, I think third generation is the issue. Basically, I would like to see what other medications she is on besides these two medications. Also, like to see other parameters of blood and all those stuff.
So other parameters of blood were normal, sir. She was on Xarelto, that is rivaroxaban. She was on mycophenolate. She was on Defcort. She was on HCQS.
Yeah. So the issue is that you give the third generation, but the timing needs to be really, really taken care of.
Okay. So this is what. So this is what I will come to Kumar also for Dr. Kumar. I hope you are there, and because whenever I'm in trouble, I would do actually is to pick up my phone and call Kumar, and if it's my lucky day, he'll pick up. If it's my not so lucky day, he will pick up the next day. If it's my normal day, he'll pick up after a week. So, so we will listen to that. So if you look over here, I have taken out the FDA forms over here. And if you actually see over here, interstitial lung disease actually occurred in 4% of patients of Tagrisso who did not have an underlying ILD. It occurred in 1.6% of, afatinib. It occurred in probably around 0.5%, 0.8%, and 0.5% for patients with decometinib. So probably, and we were not very sure actually whether we can actually dealing with lymphangitis carcinomatosis. So my question to you, Dr. Kumar, Kumar is there? Dr. Kumar is there?
This is your normal day.
This is my normal day. So maybe I will get a call tomorrow in TMH, EBM. Okay. So this is in patients, and your trials have always excluded patients with ILD and everything. So with this, and the second very important point which Dr. JP Agarwal brought away was, please go back and read the, because I also didn't know this, go back and read the drug interaction of HCQS and osimertinib. If you have given an HCQS and osimertinib, you cannot give osimertinib for 3 to 4 months because the drug half-life is such, and there is a high chance of increasing a QTC interval. So because the patient was high-5, we also read, and then the patient was started on gefitinib by somebody else. We then came and gave osimertinib, and then we stopped osimertinib, and we put him back to gefitinib, which is fair enough. So then let's see what happens. The patient was started on osimertinib. It was later changed to gefitinib. There was no improvement in symptom. She required multiple pleural effusion tappings. On a good day, she will say, I'm feeling better. or normal day, the son will start telling me we have spent so much on osimertinib and gefitinib, and you are the one who was not giving us the best medicine. And then we inserted an IPC, and then a CT scan chest was done. So this CT scan chest was done after 3 weeks. So this lady came to me in November. This is December. And if I have to read over here, that is a known case of CA lung, ill-defined heterogeneously area, what blah, blah, blah. There is some interlobular septal thickening. Bilateral pleural effusion are there. Possible DDs include progressive disease with lymphangitis carcinomatosis, bar inflammatory changes. Now, and there was one more thing which is written, which I didn't say, the dreaded 3 words, clinical correlation is suggested. Now, I didn't know how to clinically correlate the patient, whether it was an ILD which was getting more, whether it was an lymphangitis which was getting more, whether it was a COVID which was getting more, which is a secondary infection which was getting more. So let me turn my attention to Sachin and Ankur. What will you do now? 4 weeks, the disease seems, the lady is, multiple IPCs requirement. Your best treatment of gefitinib is, this is what is showing over there. So Sachin.
Yes, in view of it is EGFR mutant positive, we can go on your KN regime, sir.
The KN regimen, that is what Kumar is having a silent laugh over there. यार मैंने तो पहले कहा था KN regimen दे दो. Okay. Ankur, what would you do?
And now the patient has developed, we don't actually know whether it's a progression, patient is not responded, or whether it's ILT. We should confirm it, sir. Because
okay, you want to confirm it. Fantastic.
Because we don't know whether patient is responding or not. So whether it's just the increase in the ILD findings or the primary lesion is also increased, that will help us to identify this particular progression or not. And based on that, so still the patient previous slide.
It's okay, Uncle. You can understand my plight, I mean, you're having difficulty in speaking. I had to face that guy left, right, and center, Every 3 days that guy will come and ask me, ab kya kare? I said, jo same 3 ghante pehle bola tha, wahi karenge. But then the second savior that I have, if Kumar is not picking up phone, is Amish Vora. So Dr. Amish, serial ECGs were done. We did stop HCQS, we put him on steroids. But if you give HCQS, you can't give osimertinib for 3 to 4 months. So Amish, if I can't get Kumar, I'll call you. So tell me, Amish, what would you do?
No, actually, right in the beginning, I would have said, because the way you have presented, the obvious answer, osimertinib, was not the right answer. That much I could have told you for very clearly. And then I would have said, okay, Kumar and Narona regimen is the next best what we can do.
But Amish, the patient was PS2 at that time, 2.5, 3, She was not a very good PS with such a the point here is, Amish.
What the PS2 is the classical of KN inclusion criteria. They were brave.
No, only 20% of patients had that this thing.
No, they have brave enough to take PS2 and CNS metastasis both, So I think PS2 was the inclusion criteria. And it's present.
I can tell you, Amish, the point over there was with so much of morbidities, if she would have died into a complication, then they would have told me that why didn't you give oral TKI only? So, I mean, I'm just discussing, this is just fun.
There is never a right. See, patient was symptomatic, Ullas.
Yes.
And between gefitinib alone and gefitinib plus chemotherapy, we had a better chance of improvement in this thing. Explaining to patient, and who can be the more master than you, Ullas. You may call Kumar, you may call me, but ultimately you are the master. We all know that. So go ahead and take it forward.
Wait. I have some good things reserved for you also, but what will you do right now? Ab jo ho gaya, wo ho gaya. Batao, ab kya karna hai?
No, I think by this time, how much was the time spent for
1 month?
1 month.
Yes.
I think serial. I was while you were saying, I was just on the other computer reading, and one of the recommendation which was suggested that you keep ruling out torsades de pointes and QTC interval, and you can give osimertinib once you have stopped HCQ. So that is one option. Second option is again give.
You were doubting my statement that you can't give, huh? Okay, fine. okay. The Dr. JP देख लीजिए इनको. Okay.
Second thing is, I think if you can do a liquid biopsy at this time, which can suggest if any of EGFR TKI mutation is present, then you are well justified in either starting chemotherapy or Ullas Batra's regimen of ABCP.
So now, this was a CT scan, and it was a very scary, this happened. So this lady came to me in November. This came in the month of December 30th, 31st, I think is the one when the scan was done. 1st January was when I got COVID. And this is what it was showing actually over there, So COVID was also a differential in our mind at that particular time. We did do an EGFR mutation. It was present at that particular time. And this was very scary looking, this thing. So I see Dr. Mahajan is there, I guess, in the second panel. And if I can ask a radiologist, anybody who is there to actually comment, I mean, those three dreaded words, that clinical correlation suggested: inflammatory bar, infective bar, lymphangitis bar, COVID. I mean, we need more. So is there any radiologist present over here who can tell us more about it? Okay, I don't think anybody is there. Fair enough. So this was a real dilemma that we actually faced in this particular patient. And this is the scans that actually were there, which was very, very difficult. So we were caught between the devil and the deep blue sea. And just in case your job sucked, I mean, there were much more difficult things over there. So this was one particular case. We gave steroids. We gave high dose steroids. The patient improved a bit, but she could have improved both in lymphangitis carcinomatosis as well as by if it was an inflammatory disease. Now I like to ask, and I think it will, okay, I think it will come over there. Okay. So this is what the EGFR associated lung injury is, and this is what the pneumonitis actually shows. And you have a multiple number of patterns which can be there. You can have NSIP, you can have hypersensitive pneumonitis, you can have a diffuse alveolar damage. This is a very nice paper from the Fleshner Society, which I would request everyone to do. I'll come to Dr. Neha Sethi. Dr. Neha Sethi, if somebody was brave enough in doing a biopsy for this patient, do you think I would get something out of it? Because my pulmonologist says, A, you ask him to do a biopsy, take a consent for ventilator. Is there a specific histopathology which will tell me it is drug induced or if it is just a hypersensitive or a viral pneumonitis?
As per my knowledge, sir, I don't think any other specific finding is there related to the cancer or the drug-induced therapy, because it will show the same features as interstitial lung diseases.
So it will
different
not
types of, you have shown that these are the different morphologies and it will show the same thing.
So this will, I mean, we also ask our pulmonologists, and oncologists always want biopsy. So my pulmonologist said the only thing it will rule out is if you get a bad pseudomonas or a gram-positive thing in the bowel or microbiology, that will only tell, or a virus out of it. So we didn't really go ahead with that. Now, this is my question to Dr. JP. Sir, you have a 45-year-old female, somebody else, EGFR mutant non-small cell lung cancer. She was planned for EGFR TKIs. Let me go to Dr. Ankur. Ankur, she has brain mets and she has liver mets, lung mets. Now, Dr. JP actually wants to give whole brain RT. The patient is not amenable to SBRT or SRS. When will you start? Patient is not affordable for osimertinib. When will you start EGFR? Do you give it together with brain radiation or do you delay?
So if the patient is, it depends on if patient is asymptomatic, I'll just start them on the TKI. But if the
patient had an episode of seizures, headache, vomiting. Let us say patient requires. Let us not be politically correct.
And then, sir, I'll start RT along with the TKI, sir.
You will give RT along with the TKIs. Fantastic. Ankur. Oh, sorry, Sachin.
So I also start TK and RT together, sir.
Okay, Amish has already although switched off his camera, but Amish, I'm going to ask this question to you. Are you going to start TKIs along with RT?
What is the rush? So I think complete radiation and then start TKI.
Okay, the patient is PS2.
Yeah, well, you are giving radiation. Dr. JP ke saath, if you call Dr. JP and say, "Ke sir, 10 din mein khatam karo," he'll complete in 10 days.
It will be 5 days only. 20 by 5.
20 by 5. Dr. JP will never give. Sorry.
I didn't know that. Dr. JP, my radiation guy will give.
Last, what happens? I will sorry to interject. So generally, if they are so symptomatic, I give steroids, right?
Yes, sir.
Along with that. So, and steroids and again the TKI, sometimes you are a hitch. So generally what we practice here, the moment I complete, then Kumar and colleagues start TKI.
The KN regimen, sir.
They may do also KN depending upon the PS. Or if the patient was on TKI and then had symptom, then I think the TKI is not stopped unless they are giving steroid and all those things.
So typically, we also don't give TKIs along with radiotherapy either to brain or bone. I mean, typically, I would agree with what Amish and Dr. JP have said. We don't actually give. We let them complete radiotherapy. In fact, if the patient is stable, I want to wait for 3 more days and then give. There is no hurry as such over there. This is what typically I do. If the patient is so sick, then I don't then I tell Kundan that, let's give TKIs first and then after 2 weeks you do. So we don't usually give it together. That is what we do. So that was the first panel. Amish has already told me that I have 2 more panels. This is the second panel in which my panelists are Dr. Manoj, Dr. Archit, Dr. Manish, Dr. Pushpak, and Dr. Deepak. And I would request my existing panelists to please stay put over here so that we can discuss with them. And can I please request everybody else to please put on their videos also. So ALK in a COVID positive patient. I mean, for me, COVID positive patient was we had a series of lectures. It depends on the waves. Whether it was first wave, second wave, third wave. So let me talk to you about I think Dr. Deepak Shukla has put on his video. How was your experience of treating lung cancer patients during COVID? Was it different according to the waves? And did you stop treatment, didn't stop treatment? What did you do? Dr. Deepak Shukla.
So, sir, actually, it varied on the wave. So initially in the first wave, we were very apprehensive. But means in the second wave and subsequently in the third wave, particularly in the third wave, it was not very severe. Possibly in the second wave, it was the toughest. And majority of the patients, I did not change my treatment plan. Means I followed what I would have given in a normal setting based on the indication.
So now my specific question to you, Dr. Deepak, would be somebody who was ALK TKI just started on, or somebody was recently diagnosed with the NSCLC, and during routine, we also got a lot of COVID done. At that time, ALK came positive. Would you wait for the COVID wave to go and then start TKIs, or you would start TKIs whatsoever?
Oh, sir, I'll start TKI.
In the second wave? In the the third wave is absolutely okay. Second wave.
Yeah.
Okay.
Anytime.
The patient had was admitted in the hospital, required oxygen.
No, patient is having COVID, means patient is diagnosed case of COVID with ALK positive non-small cell lung cancer. So both so both together, then it depends on the disease burden. So if the patient is having a disease which is slowly progressing, no visceral crisis of a sort, then I'll wait, sir. Definitely wait.
Okay, you will wait. Okay. Yeah. Dr. Archit?
Yeah, I would agree with Dr. Deepak, sir, that if the patient is not much symptomatic and if we can wait for at least 10 to 14 days, then I would prefer to start TKIs once he is out of COVID.
Okay. Dr. Pushpak?
Yes, the same here. So I'll also agree with all the other panelists. So it depends upon the severity of the COVID as well as the burden of the lung cancer. So both we have to kind of balance. If the patient is too symptomatic for the COVID, I'll prefer to wait for at least 14 to 20 days and then start.
Amish had a yin yang. Initially he was saying this, then he said this. No. So Amish, your take on this?
No, I think there are quite a few case series of ALK and COVID, except for one case report where they had stopped alectinib during severe COVID. The rest of all, they have continued of ALK inhibitor. And they have found that there was no difference between what they have done. There is no clear-cut consensus guidelines, but what I think is based on these mild to moderate COVID, there is no harm in continuing with ALK inhibitor. Severe COVID patient requires BiPAP, CPAP, or ventilator. It becomes from case to case, tumor board decision, basically.
True that. This is what I just wanted to show. This we participated in the TerraVolt study where we were the 15th highest number in getting COVID data. This was a JDO publication, and we basically found out that there was no way that you could stop alectinib or crizotinib during this. And this was my own paper which I presented in ESMO 2020, in which again we found out that giving chemotherapy or giving ALK TKIs did not have an any issues with that. So
Sir,
I would
just-
agree with almost everyone. If
Yeah,
a patient,
so for a new patient,
Yes.
will you wait or
no, I
you
have
will
started.
start? Means
I have started.
so
I have started.
okay.
I'm going to come up with probably around 80-90 patients of mine with only lung cancer and COVID, distributed over wave 1, wave 2, wave 3, about what we did. I mean, wave 3 was cute. Wave 3, so nothing happened. Wave 2 was a scary part. But so if it was, we have not started, the patient is stable, did not require oxygen, I have started. If the patient is stable, I have continued. Yes, if the patient required tocilizumab and all those things, then obviously we had not given because of fear of the interaction. But by and large, COVID and cancer have gone hand in hand altogether with that. So that was about the ALK. Now that brings me about CPI and lung pneumonitis. And can I invite my panelists, Dr. Amish, Dr. Bhavesh, and Dr. Suman Kalyan. And Dr. JP Dwivedi can obviously stay over here. I can see Amish, but I can't see Dr. Bhavesh and Dr. Suman. Are you guys here? Okay, Suman is here. Okay, 2 or 3 are good enough, not an issue. So this was about CPI and lung pneumonitis, and the moment I put CPI and lung pneumonitis, my Microsoft only PowerPoint only told me the slide design that you should put like this. And my first reactions on this, no, you try it out. Put the new Microsoft 2022 and it will show CPI and with this. My reactions over there was, yeah, even isko mujhse zyada pata hai pneumonitis ke bare mein. And I was like, zapped. I was like, this is time to, probably read something over there. So my first question to the IO king, and everybody knows who is the IO king over here. How common is the pneumonitis in your clinical practice, and what is the usual time frame to develop this? And I'm not asking this to the IO Don over here. I'm asking this to the IO Don over here. So yes, Amish.
क्यों लेता है इतना क्यों लेता है
So if you keep a panel at 9:20, I have to do something, not to keep people
71 people attending, all 71 out of 71 would say that who's the IO king, and that is you, Last.
Kumar is not there. Kumar is sleeping, so make it 70.
First 2 patients of pembrolizumab, when it was not available in India and I was in Max, we had given. Obviously, we don't have to say that Nitesh organized these things. He's also the another king. Both these patients had pneumonitis, out of which one died. It was, I think, after 2 doses and 4 doses like that. Probably we didn't know much about how to do. We kept treating the person who died with IV antibiotics. We kept doing the BAL. And I think Solumetrol was started very late. After that, I have been lucky that I have not seen pneumonitis, but I have seen one granuloma. And when I was reading for this panel, I realized that granuloma is actually also one of the side effects of CPI and lung injury, because lung injury is the topic. 2.3 to 2.4 months is the ideal time. Within this period, it develops. Melanoma, they have said it can go up to 5 months also, but we don't see so many melanoma patients. So 2 to 3 months, extremely rare after 6 months.
Okay, so that is what was there. I mean, and that is why Amish Vora is the king. He reads even as a panelist, whereas I don't read as a moderator for panel discussion also. So this is very interesting. Okay, these are 2 cases which I have just seen yesterday and not last week and last to last week. Very honest cases. 60-year-old male diagnosed as a case of recurrent CA oropharynx on nivolumab for last 1 year. The PET CT scan is in CR. The last dose of nivolumab was seen on 31st of January 2022. He took very irregularly, okay, some 3 weeks में एक बार, 4 weeks में एक बार, जब पैसे हो जाया करते थे तो आ जाया करता था. And a patient took Covishield vaccine on 3rd of February 2022. He got fever on 5th of February. I said, हाँ, COVID का vaccine लिया होगा तो हो सकता है. And a disclaimer, since Dr. Parekh is listening and commenting, please अपने local doctor को जाके दिखा दीजिए. After that, but take Crocin. And he got fever between 9th and 5th. He got breathlessness again from 15th of February. And, he came to and showed me the PET scan. He came and showed me the report on PET CT scan on 15th, which said there was some ground glass opacities, which is there. Now, this is 1 year later to that. Okay. On Thursday, he came and spoke to me and I said, nothing doing. He's absolutely okay. Meet a respiratory guy. On Sunday morning, this guy comes and tells me, this guy comes to casualty with an oxygen requirement of 10 liters per minute. And these are the scans, So when I did discuss this, the scan in my tumor board, he said, ye lung ka super scan hai. Ye scan nahi hai. I mean, his lungs were like this. So now imagine this is on 22nd, but I had one more images. I was on Sunday morning, just getting out of my sleep. Again, 3 differentials. It could have been a COVID. COVID has not yet gone. It could be the COVID vaccine induced. It could be IO induced. It could be inflammatory. It could be viral. So these are the scans which of the patient which was there. Patient is in casualty, 10 liters. Suman, what would you do?
Sir, blame it on COVID and get the hell out of here.
So blame it on COVID. COVID का test कराया. Unfortunately, test came back within 1 hour. कुछ नहीं है.
Okay.
COVID negative. हमारे यहाँ थोड़ी report जल्दी आ जाती है ना.
Yeah. So, next
so
thing,
COVID negative. But then, you know, COVID by RT-PCR will not pick up a lot of things. Now, the first thing was admitted in normal ICU, COVID ICU. So we got into COVID ICU, shifted to normal ICU. What would you do now? Amish has a frown on his face right now after that.
I'm just trying to think that are you tricking us by just putting Covishield in between when it has got no...
No, I am not tricking you. I'm just telling you. This was presented by my resident. Yeah, I didn't even know he has got this. Okay.
Very, very interesting. Honestly speaking, you'll have to tell us what happened further because COVID pneumonitis jaisa to nahi lag raha tha because COVID came negative. In a bilateral ground glass opacities, non-specific pneumonitis type pattern. Is this something?
This is the real guy. I mean, you know, 20th February ka scan hai ye wala. I mean, these were the scary scans. When they sent me these scans over there, I said, kiska hai?
3rd day of Covishield vaccine, the 4 days of high-grade fever is something, you know, completely different out of, you know, it's complete. You'll have to tell us, Ullas, what happened further.
Okay, so the point here is, so this is what, first of all, I'll show you. This was my reaction over there. मैं क्या करूं? You know, the residents are waiting for my call. My juniors are waiting for my call. कि अब Dr. Ullas बताएंगे क्या करना है. I said, okay, काम करो पहले तो इसको. So we said, okay, it was Sunday evening. Yes, we did later on. So what we did was we did put this patient on steroids. I did ask them to give Solumetrol 125 under the cover of antibiotics. I put him onto Magnex. I put him onto Ezi. The infectious disease guy came, and then we got a bronchoscopy for him. And the bronchoscopy blood culture revealed a gram-negative sepsis, Pseudomonas and Klebsiella. So my point again is, yes, immunotherapy can cause this, but you need to think about other things also. The guy is absolutely okay now. 5 days of steroids and antibiotics. Discharge him today on septum and stuff like that. So one more case, last 3 minutes. This is also, I think, Amish, we do share. No, we don't share this case. We share some other case. A 45-year-old female, known case of CAD, ejection fraction 30%, stage 3B non-small cell lung cancer, got CTRT till August, severe RT-induced esophagitis, and I hope Dr. JP Agarwal is there who can answer. Okay, sir is there.
Sure.
Yeah, and Manoj Mahajan also is there. He got severe RT-induced esophagitis, CT chest and abdomen after 8 weeks, partial response. We've told him congratulations. We put him onto durvalumab. CT scans after 4 cycles, response to treatment. After 6 cycles, she came with increased cough and breathlessness. And this is what the CT scan actually showed in the month of December. Again, COVID is there. So, sir, ye batao, how do you differentiate between radiation pneumonitis and IO-induced pneumonitis?
Can you go back one, Ullas?
Yes.
Yeah, keep it that. That gives a better because the other side is also affected.
Sure. So, sir, Dr. JP, I mean, this is the problem which I'm facing left, right, and center now. How do you differentiate? And if any radiologist also is there, I'd like to take their comments also.
So it makes sense that his cough, etc., started something like 5 months or 6 months after the completion of radiation. So I will go back to my radiation profile and the areas where I have given a higher dose, and I will try to correlate whether the area of ground glass is at making that area. So most of the time, radiation pneumonitis is exclusion diagnosis.
Yep.
Include viral, bacterial, but you treat aggressively with steroids and antibiotic cover, just like the last case, and cultures, and things settle down on steroid most of the time.
Okay, Amish has a point, sir.
Yeah, so you know the JP sir, as usual, सोच लो हम लोग टाटा के कॉरिडोर में खड़े हैं.
Yeah, that's fun.
This patient has bilateral lung changes. On one side, you know, you can see there is organizing pneumonitis type of picture. Other side, there is more like a hypersensitive type of pneumonitis. To me, this more looks like, and within 6 weeks of starting, I think 6 weeks of starting durvalumab, right, Ullas?
No. After 6 cycles, so after 3 months.
After 3 months. So
3 to
assuming
4 months.
it's still in that
So it
window.
is 5 months since the last RD.
Correct. So I would put this patient as IO-induced pneumonitis, Ullas. The only point is we'll have to grade this IO-induced pneumonitis. Did he require oxygen? Was activities of daily living compromised?
So the point here is, Amish, she also had an ejection fraction of 30%. So सांस तो वो फूल ही रहा था. And the second thing was, we gave her steroids. She improved very, very well. When we were tapering on the steroids, she then caught COVID. So again for COVID, she had a very high CT, a low CT value, and again there was an issue. So she has been on steroids. She's absolutely okay. My question to you, Amish, now is, will you re-challenge?
I thought I am going to ask you during my moderation.
So what I understand, Ullas and Amish, we should not have tapered off the steroids, so soon. Irrespective, it has to be very gentle tapering off.
We gave it over a month, sir.
Over a month and a half.
December में था, January की उसमें तो 5 हफ्ते में किया था.
That is what Ullas has done, and she caught COVID basically rather than catching the pneumonia again. Ullas, durvalumab, if you see, I think you'll have to sit and see partial response. So durvalumab is probably can be life saving for this patient. One, I will give a trial because people have tried up to grade 3 of IO pneumonitis. And they have obviously, instead of 4%, it may be 8% or 11%, but remaining 90% still will benefit out of re-challenge. So if patient is treated by Ullas, I would give re-challenge.
ताकि case हो तो मेरे पे हो. Fine. That's nice. So that was my last case, and I think I am at my fag end. Yes, Dr. JP, you have a point.
So this patient has a partial response, and I will go with the response at some point of time before re-challenging. If there is a PR or a good response, the likelihood I'm not going to do anything with her. Her cardiac functions have not improved, right?
Yes.
So I will give a real break, let her come up, let her basically become a good PS.
Such a nice one, no? The medical oncologist says since she has a response, we will give. The radiation oncologist says since she has a response, don't give.
No. So that's what I'm trying to say. They have a sustained response.
So hold on. Sustained response has to be given over a period of 1 year, no, sir. You can't stop it at 2 months and then give, no, sir.
I will tell you, Ullas. So now, let's
not
say
agreeing on this, sir.
No. Let's say Herceptin, you were practicing 1 year. Now you came with the meta-analysis.
Sir. Don't compare a breast cancer to lung cancer. Sir. बहुत दर्द होता है, sir.
Okay, I am
the
comparing
worst of breast cancer is
absolutely
better than my lung cancer, sir.
Okay.
So this was my last one. Suman, what would you do? You are the last one to answer. JP says no. Amish says yes. What would you do?
Sir, I would like to re-challenge. Given
you are a medical oncologist, we all like to re-challenge, especially to somebody else's patient. Okay. So this is my last question to you, Dr. Amish. What do you do when you hate your job?
What do I do when I hate my job?
If you don't hate your job, but just in case you hate your job, what is the advice to them?
I think we should have 1 hour of webinar on this, and we will very soon organize that. I think you should always, if you're financially secure, you go what your heart says. If you're financially not secure, balls to your head, continue working.
So the problem over here is, this is what I didn't expect this kind of an answer. I said, let's meet at the bar. So, this is what was there. So I think if we are sick of all these toxicities of this, let's meet at the bar. So my conclusions for today, basically, there's so much to learn. The more you read, the more these drugs, there is so much to learn. And I'm so glad that we have learned. I learned a lot out of this panel discussion, and so nice of you. Thank you to all my panelists, and especially thank you to Dr. Hemant and Dr. Lalit to give me a topic which I could learn. Thank you, sir. Thank you.
Thank you, Dr. Ullas, for the nice moderation, and all the members who has participated, and a special thank to my teacher JP sir.
Good night.
And now I will invite my close friend Dr. Amish Vora for his expert comments as usual.
Thank you, Bhati Saab. Such a wonderful thing to see you since last 2 hours, and that also frequently. That made my day. I have spoken a lot, so I think if Dr. Archit wants to, if he's there, and if he wants to conclude, I will be more than happy to do that. My just last thing, Ullas, thank you for presenting the second case. I really felt that everything is not as it seems to me. You should always have differential. Young patient, gram-negative sepsis, if not treated, patient would have died. So thanks that. And with that, in case if Archit is there, I would request Archit to conclude the comment session.
Yes, sir. Actually, thanks a lot, everyone, Dr. Amish, Dr. Ullas Batra, sir, for extensive, elaborative case discussions. Just one more thing I would like to add regarding ALK inhibitors and drug-induced pneumonitis. So actually, drug-induced pneumonitis with ALK inhibitors are more common with crizotinib, ceritinib, and brigatinib compared to alectinib and lorlatinib. But I want to talk specially about brigatinib. The drug-induced pneumonitis with brigatinib is actually reversible in quite a few number of patients, and patients were re-challenged with brigatinib once he develops brigatinib. So many of the patients were re-challenged with brigatinib, and I feel the mechanism of development of pneumonitis is a bit different than other ALK inhibitors.
Kashish, do we have any questions which were there in the chat box and we have missed out? Whereas Ullas doesn't miss out any chat box, but in case if we have missed out.
Sir, we don't have any
Chatting
questions.
is more important.
Sir, I thought you had a question. You had put something in the chat box.
No. I think I had asked all the questions. Ullas, just last, because it was the question was not answered. Which patients of durvalumab and IO would you re-challenge, or are you re-challenging, and what are the criteria you are using? With that answer, I think we can close this session because we are just.
I think very simple, Amish. I normally follow what the trials have said. If it's a grade 2 or lesser, we would do. You only said that. Grade 4, I will not do that. Grade 3, I will look at how young, how old the patient is, what the response is. I think I always say it's the art of medicine and not the science of medicine that I practice. Science तो वैसे भी नहीं आती है सर. आप लोग सारे हो, मैं art कर लेता हूँ.
How many have you seen pneumonitis or re-ICIs?
Not really. I mean, so I have not re-challenged much. I've been very fortunate enough. But in the 3 patients that I have re-challenged, nothing. All cool. But I give them a good steroids. I give them very good steroids. I break it for 2 months like I did for this patient. I'm going to re-challenge this patient in the next, I think 7 days. I've asked them for a PET CT scan and then take it from there.
Great. Hemant sir, Lalit, Mohan, Sharma sir, and Bhati sir, thank you so much. And with that, we conclude this session. Ullas, thanks a ton for such an amazing case. Superb.
Thank you. Thank you. Bye-bye. See you.
Thank you everyone for joining us for day 1 of the conference. We request everyone to join us tomorrow at 5 p.m. for day 2 of the 46th ICON conference. The topics that are going to be discussed are going to be on breast cancer, ovarian cancer, prostate cancer, and bone and soft tissue sarcoma. With that, we come to an end of day 1, and good night everyone, and hope to see you tomorrow.